All righty then. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, September 4th. Technically, it is Labor Day weekend. It is a holiday, and so we'll see if anybody needs any support today. If not, that's perfectly okay. We out here in California, the reason why I'm a little bit late is because we are just starting this massive heat wave. We're expecting 114 degrees 2 days in a row starting tomorrow. It's supposed to be 106 today. And so I have been up since 8 and prepping my entire home for this extended heat when you don't have air conditioning. I've got some window air conditioners. Yeah. So send lots and lots and lots and lots of support to the West Coast for this extensive heat wave. So anyway, listen, my name is Jill Osborne. I do weekly support group meetings. I try to do weekly support group meetings, sometimes 2 a week here on the internet for patients who are newly diagnosed with IC and, of course, grizzled veterans. Hello, Sylvia. Nice to see you. My purpose in doing these meetings is to make you so strong, so knowledgeable, and so educated that no one can mess with you again. I don't want, oh, crap, hold on. I'm missing sound. I can fix that. Dang it, dang it, dang it. I hate it when I do that. All right, Facebook. Do you have sound? Okay, do it now. Let's try that again. Facebook, do you have sound now? Yay! Hey, listen, I've been slammed today. It's been a very, very busy morning. Yes. Excellent, excellent. Hello, Darlene from Virginia. Hello, Deborah. Nice to see you. So I'm simulcasting right now. If I'm looking straight, I'm looking at Facebook. If I'm looking over here, I'm looking at YouTube. And again, as I was saying before we figured out that the sound wasn't set up correctly on Facebook, is I try to do these meetings weekly because I want to give you knowledge. I want to empower you. I want to give you hope. I want to give you strength. I want to give you a kick in the pants if you need a kick in the pants. You'd be amazed the number of times I do that on the phone with people. Now, I always say, listen, my job as a support group leader is to educate you, but you can't kid a kidder. I've been where you are. Thus, I can call you on it if you're doing something you're not supposed to do, you know? And so it's kind of a fun but delicate part of my job. Obviously, I'm not a doctor. I can't give you medical advice. That's not my job. My job is to try to get you back to your doctor with a whole new set of questions. And speaking of a new set of questions, hello, my friends. It is IC Awareness Month. September is IC Awareness Month. This is the time of year where IC patients gather together to share our stories. Now, obviously, this was extremely subdued during COVID. We had other fish to fry. And so this year is still going to be a somewhat modest IC Awareness Month. But that's okay. Things are definitely on the mend. Things are definitely starting to get better for all of us. And so what is IC Awareness Month all about? Now, listen, back in the old days when I was first diagnosed, IC Awareness was run by the company that had Elmeron. And so it was just basically a promote Elmeron thing. That didn't go well. IC Awareness started with a day in November. It was like the day before Thanksgiving. That was back in the 80s. Somehow that got derailed, and then it got moved to a week in October, and the pharmaceutical company was running it then. And then, hi, Barbara, they backed out. They decided that they didn't want to do that. So I waited a year because I personally thought the ICA was going to step forward and run it. I waited a year, but the ICA made no attempt to kind of go after it. And so the IC network took over IC Awareness. And I modeled it after Women's Health Week. So IC Awareness is not about me. It's not about a national organization. It's not about the ICA or the IC network. It's about you. It's about you. Hey, listen, you're the most important person in this world right now. You're the one living in your community. You're the one seeing if your community is treating you well or not well. You're the one who can see if your doctors are informed or not informed, right? And so IC awareness is all about giving you things that you can do in your community, not the least of which is sending our press release to your local paper. It costs $1,000 to send out a press release over the national media, sometimes $1,200, sometimes $1,500. And I'm not going to do that this year. We haven't done it for 3 years because, number one, money's tight for everybody right now. Money's tight for us too. We don't have a big fancy corporate sponsor for the IC Awareness Month this year. We haven't for a couple of years. And I don't anticipate that we're ever going to have a large sponsor again now that we understand that IC is a pelvic pain syndrome. So what I'm hoping that you will do instead, hi Mary, is you will send out our press release. You can email it to your local paper and say, hey, could you do a story on this? That's how IC awareness has run for the last 15 years. Our biggest stories have been from patients like you, like my friend Marie Grimes was the first person to get an article in Reader's Digest. And she just wrote him a letter. And that was a very impactful article. So you can do that too. So I wanted to read our press release to you because this is all about. So if you go over to icawareness.org, which is the campaign website, it's under Media Kit. And so I want to read this to you because this is going to segue into another area of controversy that we have right now on our Facebook page. So every year we always try to highlight something that's important that's happening. So we've done patients who have been denied restroom access, people who have been fired from jobs because they weren't allowed to go to the bathroom. That just changed again on Amazon. Like Amazon is now making it harder for employees to go to the restroom. If I saw an article last week about that. We've done articles about schools that would not allow children with IC to use the restroom during the class. Children who were punished, children who were given detention if they needed to go more than once a day. We obviously have many cases of patients who were not treated correctly, et cetera, et cetera. So anyway, we always try to pick something that's fairly newsworthy every year. So this one is the new AUA guidelines, and our title is IC is no longer considered a bladder disease. The new AUA guidelines identify three distinct patient groups. All right, so here you go. In a move that has taken many clinicians and patients by surprise, the AUA no longer considers interstitial cystitis a bladder disease. Updated guidelines released in May of 2022 suggest that IC is a pelvic pain syndrome and that patients fall within three distinct patient groups: bladder wall driven, pelvic floor driven, and chronic overlapping pain conditions. Quote, bladder wall driven is the most logical subtype. These patients can have Hunners lesions, genitourinary syndrome of menopause, chemocystitis, or perhaps chronic UTI, offered Jill Osborne, founder of the IC Network. Their treatments will focus on the bladder wall. The AUA recommends that patients with pelvic floor hypertonicity work with a physical therapist to resolve trigger points, ease tension, and restore normal muscle tone. And chronic overlapping pain conditions, IC, IBS, vulvodynia, fibromyalgia, TMJ migraines, appear to be driven by an underlying central nervous system dysfunction. Quote, their therapies must focus on calming the nervous system and reducing fight or flight, which exacerbates pain and increases muscle tension, offered Ms. Osborne. Mind-body medicine techniques have become an essential tool for reducing the high levels of anxiety and catastrophic thinking found in this subtype. Now, in years past, a diagnosis of IC was often confirmed by the presence of petechial hemorrhages on the bladder wall. But the new guidelines have removed this requirement, stating that these are not unique to IC and have been seen in other disorders and some normal bladders. The AUA acknowledges that no single therapy works over time for the majority of patients. Treatment should be tailored to the patient depending upon their subtype and for the management of symptoms. And if a patient is not responding to multiple treatments and/or bladder therapies are not effective, the diagnosis of IC should be reconsidered. Is another condition present that could be reducing producing pelvic or urinary symptoms, such as endometriosis, fibroid tumors, coccyx injury, pudendal neuralgia, posterior fornix syndrome, pelvic congestion syndrome, etc. Quote, one of the most common causes of severe pain in the IC BPS patient is untreated Hunners lesions, offered Ms. Osborne. The AUA recommends that lesions be treated immediately with fulguration or steroid injection. And pain should be assessed at every appointment and treated with multimodal therapy, including urinary analgesics, NSAIDs, narcotics, and non-narcotics. September 1st launches the annual IC Awareness Month campaign. The new guidelines represent a critical step forward in the treatment of IC in the United States. And with time, more subtypes are likely to be identified. It is essential that both providers and patients learn about these unique patient groups and their related treatments. Learn more about IC Awareness Month at icawareness.org. So you can head on over there and go to the media kit and you can download it. Anne says, did I start an IC Facebook? No, I did not start that group. That group was started without my permission. It was started by a former volunteer on the IC network, and it was very frustrating for me because it implied that I was directly controlling that group, and I was not. And in the last year or two, Kathy allowed me to be a moderator so that I could get in there and do things that related directly to us. But it is not an actively moderated group. It's because I didn't start it. But I do have Donna, who works for me, who runs the IC Network Forum, go over and check every now and then too. She checks about every day. Okay, so anyway, so what else can you do for IC Awareness Month? Well, you can create a poster. You can, we are still having our poster contest. And rather than having first, second, and third place, which always tortured me, it's hard to pick who should be first, second, or third. What I'm going to do instead is I'm going to do gift cards for all the entries that I think are put an effort into it. So those will be Amazon gift cards. I'm not going to tell you the value. Some of them might be high. Some of them might be anywhere from $25 to $100. We'll see. I'm just trying to give myself a little bit of flexibility here. We also have our meme contest, which is a great way to kind of spread the news about IC and get it going through social media. So you can do really funny, snarky things there. You can make a donation to IC research. You can buy our book IC 101 and donate it to your library. There's just a lot of things that you can do. And so there's this quote that I think is very important. If not you, who? There isn't some magical organization that's going to step forward and spend $50,000 and plummet the airwaves with stories about IC. Not going to happen. Not going to happen. And it hasn't happened for 15 years, 20 years. It is all about what do we as a community want to do. So I'm giving you some tools and I'm going to kick you in the tush and say, all right, run with it. Let's see what you do. Let's see what you do. No pressure. No pressure. You know, I would think it's important that if you're up at night and you're crying in pain and you've had a rotten night, that's a perfect time to use that pain constructively. You know, get on your computer, write a letter to your senator, write a letter to your congressman, write a letter to the mayor of your town, and tell them how you're suffering. Share with them intimately how difficult this makes it for you, and then ask them for help. Ask them for help, whether it's restroom access, whether it's getting more disability cases approved. Use that change for, use that pain constructively. You just need to use that pain constructively. All right. Alrighty here. Hold on. Somebody is emailing me and I get distracted. So I got to shut that down. Now, one thing about IC awareness that I do is I have a series of daily facts. And so I put them up every day. They're rewritten every year. I'm already rewriting all the daily facts. I'm creating new pictures and images for the ones that we're phasing out. And yes, and doing new ones in. And so we have a little kerfuffle happening here on Facebook about our daily fact for yesterday. And that was indeed the one that I changed that talks specifically about the American Urology Association very clearly saying that they do not believe that this is a bladder disease anymore. And let me read to you some of the responses because I want to address them because they're all valid. Nobody's saying that people are wrong. They're valid. But I want to try to explain them. Let's see if it'll let me do it. Hold on. Judy says, if you get BV, can your husband get it? Potentially, you can cross-contaminate each other. Here, all you guys, give me a minute. I will come back to your questions. Please, if you have any questions, please send them out to me. I would be happy to answer them. So daily fact number one was that millions of patients around the world have this. Obviously, we work with patients in over 90 countries. It affects every age group. It affects every culture. Injuries can happen to anybody. Okay. And then our subtype number two was about Hunners lesions. Hunners lesions affect 5 to 10% of patients, and they're one of the great mysteries of IC, what causes them. We now believe that for many of you, they're viral in nature. That it is a polyoma viral infection. That's not a sexually transmitted disease. It's one that we all have. It just gets turned on in some people. But daily fact number three is that new AUA guidelines, the IC is no longer considered a bladder disease. And so let's go over some of these comments here. Kasha says, it just makes sense to me that anytime you have pain and inflammation and injury, the muscles will tighten and guard around to guard the area. For those of us with IC, this can turn into a perpetuating cycle. So, of course, there's a neuromuscular connection, but please do not use that to discount the fact that if one has Hunners ulcers, it is an undeniable disease. Now, I'm going to say yes, and I'm going to say no. If, as the AUA says, if there's any evidence of infection, that is a disease process. The challenge here is the great majority of IC patients do not have active infection. Some of you do. A very small population of you do, which helps us understand the 5 to 10% who might have Hunners lesions. But for the rest of us, there's not a visible active disease process. So if a Hunners lesion is viral, then yeah, that's a disease. And they say that in the guidelines. Okay, but remember, we had a case study that was released last year, which is absolutely remarkable, of a woman who had severe Hunners lesions. She was completely disabled by Hunners lesions, and she had a severe prolapse. And when they went in surgically to repair her prolapse so that she could urinate, they made a remarkable discovery that the back side of her uterus was facing the front, and the front side of her uterus was facing backward. What had happened in her case is that one of the ligaments that normally holds the uterus in place was broken. And so her uterus was swinging like this. And what happens is you get a twisting of the tissue. We call that a strangulation. So her uterus had twisted either once or twice and was now facing in the opposite direction it should face. So when they went in and they surgically repaired that and they restored the position of her uterus, what happened? Her Hunners lesions healed completely. Published case study. This is called posterior fornix syndrome. And I've now worked with several patients who it turned out did have posterior fornix syndrome. And so that clearly is not a disease. That is, in fact, a strangulation. That is that when you twist tissue, you're twisting nerves, you're creating irritation and inflammation in the nerves. But when you restore that position, it goes away. All right. So I want to say that. Kasha says, I know it's sad, but I wonder what's the motive behind this move. It's a correct move. Because as they say in the AUA guidelines, a one treatment fits all approach does not work. Why? Because many of us simply do not have bladder dysfunction. We don't. This is why we subtype. And they focus on 3 groups. Of course, I used the Chris Payne system that was developed 6 years ago, which I think is a better system. They focus on 5 groups. Hunners lesions, that's a separate group. Bladder wall driven, and that's going to be chemocystitis, estrogen atrophy, or chronic infection. Pelvic floor driven is number 3. Pudendal neuralgia is number 4. Chronic overlapping pain conditions is number 5. And what we know from the last 50 years is if you keep telling everybody they have a bladder disease and you give them bladder therapies, many are not going to get better. I work with you every single day. Listen, I had symptoms in 7th grade. I'm 62. The majority of my life, I have had symptoms. I did bladder therapies for decades and never got better. Never. Why? Because it's not my bladder. It was my pelvic floor. And it was pelvic floor physical therapy that stopped the bladder pain, that stopped the vulvar pain, and got me to a better place. And ironically, if you go back to when I was in 7th grade, I had broken my tailbone a month or 2 before this all happened. When you break your tailbone and your tailbone heals out of position, your tailbone's supposed to be straight and it's supposed to be curved. If you break your tailbone and it's to the left or to the right and it's lost its curve, your pelvic floor is going to be affected. And ironically for me, back then, I was diagnosed with a urethral stricture. It was like trying to pee through a needle. My urethra was tiny. It was narrow. It's very, very narrow. It's very hard to urinate. So back then, what they did is they did something called a urethral dilation, where they forced a metal tube, a metal sound it's called, up into the urethra to stretch it out. And I had about 100 of those. I had them every week for at least 2 years. And then slowly it got better. But of course, today we go, wait a second, why is the urethra narrow? What forces are causing that urethra to get tight? Oh, hello, pelvic floor. Hello, pelvic floor. Mary says, how long did it take before you had positive results showing pelvic floor physical therapy? You know, my muscles were jacked up for decades. And so I'm going to say it was my first course of physical therapy was like 8 visits, and towards the end of that, but I could tell that things were changing. I was urinating more easily. I wasn't stopping and starting. I wasn't having as much pulling and pushing that tight pelvic floor muscles cause, right? All right, let's get, I just want to go through a few more of these comments here. Linda says, I disagree. My cystoscopy showed I have an irritated lining and inflammation. Okay, so what we have to do is ask, why is it irritated? Is it irritated because you've got estrogen atrophy? If that's the case, that's not a disease. That's just the loss of estrogen. We call that the genitourinary syndrome of menopause. Or is it irritated because your muscles are so tight that it's not distributing good blood supply, good oxygenation, nutrition to the bladder wall? We call that ischemia. That happens from tight muscles. You know, we're always focusing on the concept of cause versus effect. You could chase symptoms forever and never get better, because we always have to have a laser focus on what is the underlying physical abnormality. Like I was working with a patient yesterday who was really trying to figure out a way to stop a bladder infection. She kept getting, she had real bladder infections. So she not only had IC, she had real infections. And so she was doing herb after herb after herb after herb. And so she called me up and said, what do you know about this herb? And I looked at it and I went, well, that's pointless. Why would you do that? And she goes, well, because somebody said it might help. And I said to her, I said, listen, we have to understand why you're getting recurring UTI. The reason you're getting recurring UTI is because you have estrogen atrophy. As you get older, you lose estrogen. The bladder wall gets more vulnerable. It loses some of that nice, thick protective coating that normally protects it. It's well known that many women, once they're in menopause, start to struggle with recurring UTI. And she's like, well, but we can do this and I can do this. And I kept saying, none of those will help. I mean, it might help with symptom, but it'll never fix the underlying problem, because the underlying problem is the loss of estrogen. And she goes, yeah, but I don't want to do estrogen. And I had to go through the anatomy and say, listen, you want a natural approach? Well, the most natural approach you can do is to give that skin exactly what it needs so that it can produce its own mucus. That's natural. That's natural. Whereas an herb will never be able to mimic and produce mucus. So anyway, cause and effect, cause and effect. So here's somebody who says, my IC is so bad, the lining of my bladder is basically gone. It feels like crushed glass in my bladder, and when it spasms, oh my Lord, the pictures of my bladder show how bad it is and how red and inflamed it is. So again, the question is why? Why is her lining gone? And the answer is probably going to come back to estrogen atrophy. Now, remember, too, that back in the old days, when they did a hydrodistension and they looked at your bladder, they were looking for Hunners lesions, or they were looking for little red swollen blood vessels that we call petechial hemorrhages or glomerations. And we thought that was IC. We thought that was IC. And they actually put it in the 1987 National Institutes of Health Diagnostic Criteria for research studies. And another researcher went not so fast. And so he took a number of women who had no bladder symptoms. They were scheduled for a tubal ligation. And he said, can I please look at your bladder? And they went, sure. And he did a hydrodistension. And what did he find? Petechial hemorrhages and glomerations in a patient who had no bladder symptoms. Now, this is what we know, that when you stretch the bladder, that's what happens. You cause that. And so that is why petechial hemorrhaging is thrown out. So if you had a hydrodistension more than 5 years ago, they were doing high pressure, long duration hydrodistensions. They're very damaging to tissue. You all had petechial hemorrhaging, but it was because they overstretched your bladder. That is found in healthy bladders. And that is also found in other diseases when you stretch that bladder. Okay, so petechial hemorrhages are meaningless. Okay, Elizabeth says here, my cystoscopy definitely showed cracks in my bladder wall. Elmeron was my saving grace. Hydroxyzine not very helpful. Okay, so a crack, it's a very interesting term, because when we think of a Hunners lesion, we tend to think of a round wound, but Hunners lesions can actually be vertical. And so there is a chance that that crack is indeed a Hunners lesion. The fact that Elmeron was helping her, remember, Elmeron is a protective coating, that also points us right back to estrogen atrophy, quite possibly, depending upon where her estrogen levels are. Miriam says it's an embedded infection. It is not an embedded infection. The biome studies are very, very clear. They are not finding significant differences in bacteria in IC patients versus non-IC patients, although we certainly have found candida infections in some patients struggling with flares. If you flare when you eat sugar, you could have a candida infection in your bladder, but the whole theory that IC is embedded infection is thrown out. They don't recommend long-term antibiotics. This is, do I think that some of you could have an embedded infection? I think so, but it's a very, very, very small group. Here, hold on one sec. Hi there. Good morning. Oh, here, hold on. I got to go put her hearing aid in. Give me a sec. Wait, it's this here, right? Here. Let me do your hair real quick. Here. I've been up since 8.
Oh, wow.
I've been shopping. I stocked up.
Was it pretty warm even at that hour?
It's not quite as hot as they thought it would be, but it's still plenty hot. Okay. Alrighty. Sorry about that. So my mom is 93, and she just wants to sleep. She just had her blood work up. Her blood is spectacular. It's the best it's been in years. She just wants to sleep a lot. And so this morning she was sleeping so hard, I didn't have the heart to wake her up because it's going to be real hot today. So I wanted her comfortable. All right. Let's see. Kathleen says, well, the first 2 years of IC, I was receiving 2 installations a week with the exception of a 3-month shutdown for COVID. My bladder looked normal and pale pink, no Hunners. Since I relocated to another state, the protocol of this urologist is 1 installation each week for 6 weeks, then as needed. Here, 2 cystoscopies show my bladder is angry red. While the meds used in both states are similar, there was one difference. The first 2 years in another state, my installations include sodium bicarb. Here, the urologist blew it off, saying all that does is neutralize the. Oh boy, he did. Wow, that urologist is really wrong. Okay. Here's somebody who says IC came from sexual assault. I'm so sorry that that happened, and that's very true. That we certainly have a number of patients who have physical injuries and nerve injuries from sexual abuse as children. There's no doubt about that. All righty. So anyway, a lot of big things have happened this year. A lot of good things are happening this year. These new AUA guidelines are not perfect, but they represent a step in the right direction. So let's go ahead and get to your questions here. And then to these people who are responding earlier, I will get in there and respond. Righty here. Bruce says, can you please provide your email so I can connect? My email is icnetwork@mac. It's short for Macintosh computer because I work with Apple computers. I got rid of my PCs years ago. So icnetwork@mac. Hold on. Woo! Somebody did a stinker. I gotta spray my. There's a bathroom right over there. When you've got a wicked sense of smell, you can see that stuff drives you crazy. Caroline says, "Help you feeling better." Yes, my back is better. Thank goodness. Oh, my blood pressure is doing pretty good. Just I'm dealing with the stress now of the next 5 to 7 days, where it's going to be potentially 110 every day. Caring for 2 elderly people in that situation is challenging. So, yeah. Mary says, "How long?" Okay, so hold on, Mary. I did answer your question already. Anne says, "Is calcium glycerophosphate pre-leaf?" The answer is yes. Calcium glycerophosphate is pre-leaf. Pre-leaf was the first supplement ever created for patients who struggle with a sensitive bladder. It was created by AK Pharma, a doctor named Alan Kligerman, who also invented Beano and Lactaid. And pre-leaf reduces the acid in your urine. Pre-leaf doesn't act directly on the bladder. What it does is it reduces the potential irritation that acidic foods will cause. And so here it is right here. So they have worked with me for over 25 years. This is an important supplement, but the challenge here is it is calcium. And so you don't eat this like candy. If you know, the calcium has to go somewhere. And so if you shouldn't be eating it all day every day. You only take 1 or 2 capsules before a meal if that meal's going to contain something that you think is acidic. Like lasagna or something like that, especially with the holidays coming up. It's really useful to have a couple of pre-leaf in your purse with you when you go to grandma's house. But if you take too much and you're prone to kidney stones, you're supposed to keep your calcium intake down if you're prone to kidney stones. Somebody asked a question. I just put 2 more blogs up last night on our website. And one of them was a blog that Stacy and I worked together on UTI. And one of the risk factors for getting UTI actually is having kidney stones or bladder stones. That's a really interesting question. Why would a kidney stone make you more prone to getting a bladder infection? Well, kidney stones are sharp and they're covered with bacteria. And so as that sharp kidney stone goes down the ureters and into the bladder, it is literally cutting or abrading tissue. And wherever it touches and abrades tissue, it's directly introducing bacteria into the skin. So we want to make sure that those kidney stones are controlled, if at all possible. Judy says, if you get bacterial vaginosis, can your husband get it? And the answer is yes. Any pathogenic bacteria can be shared through sexual partners. And so using a condom would be very important while that BV is active. Sylvianne says, do patients with IC mostly have a weak pelvic floor or tight pelvic floor? Tight. So Sylvianne, rather than saying do patients with IC, I think what we need to start saying is do patients with pelvic pain have weak pelvic floor or a tight pelvic floor? And the answer generally is it is a tight pelvic floor, and that patient is now struggling with ischemia. If your bladder is supposed to get 24 units of blood a day and it's only getting 10 units of blood a day because your muscles are so tight, they're restricting blood flow, that is not going to be a healthy bladder. That bladder is going to be vulnerable. That bladder is going to be weak. Our therapeutic priority for somebody with tight pelvic floor muscles is to restore blood supply. That when we restore blood supply and we get a good healthy flow of oxygen and nutrition back to the bladder responds beautifully. Pelvic floor physical therapy, we knew in 2006, I think the first pelvic floor physical therapy study was published by the National Institutes of Health. And that is what put the IC movement on its head, because up to that point, then everybody's going bladder disease, bladder disease, bladder disease. Well, if it's a bladder disease, why would pelvic floor physical therapy help? And that was that wake-up call where everybody was like, uh-oh, wait, we better start looking at muscles. And the irony is, if you go back 100 years and you look at all the published papers, most of them describe muscles so tight, they're like tight piano strings. But they didn't understand the consequence of that. Remember, urologists play in their sandbox. They play in the urinary tract. So even though they were writing papers talking about very tight muscles, they weren't doing anything about it. And it really is only in the last 15 years or so that we now clearly understand the role that the muscles play. And I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? For some of you, it starts with the bladder. Maybe you have chemocystitis, or maybe you have estrogen atrophy, and your bladder starts to get very, very irritated, and your muscles get tight in a guarding reflex. So our therapeutic priority for that patient is to calm and soothe the bladder, and we're going to hope that the muscles will release once the bladder calms down. But that's the smaller group. The bigger group are the patients whose symptoms began after some sort of physical injury to their muscles. But of course, you have no idea you have a muscle injury. Your first symptom is frequency, urgency, and pain. You're saying it's an infection. And you call the doctor and you say, hey, I have an infection. And the doctor goes, all right, here's some antibiotics. And they don't work. And you go back to the doctor and the doctor does a culture and the culture comes back, hello, negative. But the doctor goes, yeah, cultures aren't always foolproof. Let's just put you on a long-term antibiotic. That doesn't work and causes a lot of damage. You go back to the doctor and the doctor goes, maybe you've got overactive bladder. And they give you overactive bladder meds like ditropan, Detrol, oxybutynin. But they don't work and you're still flaring. You go back to the doctor and the doctor goes, hey, I hate to break it to you. I think you've got this incurable bladder disease called IC. Here's the diet. Here's some medication. I'll see you in 6 months. And you're like gobsmacked. You're like, okay, I got a name. Thank God we know what it is. But wait, you're telling me I'm going to have an incurable bladder disease for the rest of my life? That is shocking. Agony, especially for a young patient. I mean, I was diagnosed with IC when I was 32. Remember, I had a doctor say to me, you will forever live with severe pain and you will be a burden on your family. Get used to it. This is your life. And that was the moment I started to fight back, right? So anyway, the doctor tells you you've got interstitial cystitis. You follow the diet. You do the Elmeron or whatever other meds they give you. You do it for a year. You do it for 2 years, 5 years, 10 years, 15 years, 20 years, 25 years. But you're still flaring. Why? Because it doesn't fix the underlying problem. The underlying problem for the injury patient is ischemia, blood supply. The blood supply is impaired. So our therapeutic priority is actually to get those muscles back to normal tone so we've got good blood supply that will then help the bladder heal. And we've got the research to back it up. We now have tens of thousands of success stories, myself included, that prove that pelvic floor physical therapy is, for many of us, far more effective than bladder treatments ever were, because fundamentally our bladder is being victimized by something else. It's not literally a bladder disease. In my case, it's absolutely neuromuscular. There's no doubt about that. Terry says, thank you, Jill. I will ask my doctor about pelvic floor when I go back. Good. Teresa says, do people know right away when they break their tailbone? Could people not notice that they broke it? You know what, Teresa, that's a great question. I will tell you, for me, I could move it. I mean, I was the kid. I was in 7th grade, but I actually broke the tip of my tailbone off. And so it was floating in there. And I could move it back and forth. And I mean, it was painful, but I wasn't crying. I didn't really even talk to my parents about it. And now, you know, what's interesting is now that, you know, all this tailbone injury has come back into focus, I started looking at my tailbone more, and I've got a like a round knob on the end of it where it reattached, and it's like so normally your tailbone would be like this, right? Or except curved under. So mine has a big round grape at the end of it, which is that injured bone. One of the other things, now you guys, you know, I have no shame. I am absolutely willing to talk about anything. I don't take any bladder therapies because my bladder is fine. I had a hydro, my bladder is fine. My muscles, on the other hand, are a work in progress. I have moments when they're good and moments when they're bad. And the other day, I started having rectal pain, like it felt like rectal pain. But, you know, I know more now. Let me get my model here. Hold on a sec. So I was in the shower and okay. So I was in the shower and I was feeling this rectal pain. I'm like, all right, I got to figure out what the hell's going on down there. And so I literally put both hands down my butt crack, right? So my hands are like this, and I just started touching the muscles, and the muscles were really painful. And so literally I just massaged those muscles from the outside, and the pain went away. And you can see that here. Okay, so here is the rectum, right? And so we've got the levator ani muscles, which wrap right around the rectum and they go all the way down. And then we've got these muscles, which, attach to the tailbone, right? The tailbone is plays a stabilizing role, and the tailbone actually moves and helps to balance things when you're moving. So look at all the muscles that are attached here. And now if we put our levator ani muscles back, you can see that connection. So what I was doing in the shower is I was doing this basically. I wasn't working on my rectum at all. I was working this muscle right here. I could feel that the muscle was tight on both sides. A normal muscle tone feels like kind of a chicken breast, right? An uncooked chicken breast, soft, loose, pliant. A tight muscle feels like painful beef jerky. It's stiff and contracted, and that's the way. And so I have been sitting for a long period of time doing stuff for the IC network, and the longer you sit, the tighter the muscles, thus explaining why my muscles right here were just not happy with me at all. I thought it was very interesting that, I mean, I'm trying to be very proactive now when I start feeling it, to just stand, and I basically had my hands like this, but I had them going down the back. Oh, no, I had my hands like this. And I was just rubbing the muscles on both sides right by my tailbone. And oh my God, it really helped. So interesting. I think about having all that rectal pain that I had in my 20s. You know, there is a condition called proctalgia fugax. Proctalgia fugax is a very violent rectal spasm. Like, it literally stops you in your tracks. You don't move for 5 minutes. It is a very violent rectal pain, very aggressive, very strong rectal pain. And I had many, many attacks of proctalgia fugax in my 20s, many. And when they go in and they do that workup, the thing is that the rectum's fine. There's nothing there. There's nothing to explain this until you look at the muscles. And so we now believe that these violent rectal spasms are actually violent pelvic floor spasms, but also spasms in the smooth muscle of the bowel that are just, for one reason or another, are just triggered. I have not had, knock on wood, I don't want to jinx myself, knock on wood, I have not had an attack of proctalgia fugax in 30 years. But I'm not lying. I had it every day for 3 years. 3 years. Every single day, 11 o'clock in the morning, I was laying on my bathroom floor in the fetal position. And that was part of the onset of my IBS, which of course we now know is neuromuscular. And it was very, very triggered by oatmeal. Whenever I ate oatmeal, that happened. And of course, if you go in with bowel issues, they always tell you to increase your fiber. So I'd been eating oatmeal every day for 3 to 4 years. And for 3 to 4 years, I was having these violent spasms. Once you stop the oatmeal, they disappeared completely. So anyway, so you can be irritated from chemicals that you're eating. You can be irritated from sitting too long, et cetera, et cetera. Angie says, because of my tight pelvic floor, my hip IT bands are extremely tight. My physical therapist did muscle scraping on Thursday. Ouch. It hurt and I'm bruised and very sore Friday and Saturday, but definitely feel better today. I had never heard of scraping. Also, do you know of lidocaine gel being used in installations? We can't get vials of lidocaine or marcaine, so we're looking into using the gel. I honestly, I haven't heard of muscle scraping. I mean, it's ringing a bell, but I can't give you where or why. I mean, obviously, I think I've read about it at least in one place. It didn't seem particularly relevant here. I'd be interested to know what they were scraping and how they were scraping it. Yes, there are shortages of lidocaine and marcaine right now because of COVID. And you may not know that China is going through their absolutely worst heat drought ever. And like 6 or 7 rivers have dried up. And that is decimating, absolutely decimating the ability of China to produce stuff. So they're saying we're going to have another shortage of stuff from China because of this. Like the biggest river in China is like bone dry, just like the Loire River in France. Oh, Mother Earth is angry. Debbie says, I'm trying to eat better and better, and I'm trying the pelvic wand. I can't get rid of this flaring off and on. I have constant belly pain. I don't know what to do anymore. I don't know what to do anymore. Debbie, when you say belly pain, can you be more specific? Is it down by your pubic bone, or is it up by your waist? Is it to the left? Is it to the right? Is it low, shallow on your skin, or is it deep inside you? Give us a little bit more information. Carolyn says, I was born with IC. I inherited it from my mother and my father's younger sister, who were both confirmed by urologists as having IC. Can a baby be capable of having estrogen atrophy? I have Hunners lesions since I finally had a hydrogestension. The urologist was so worried about me because they removed water from my bladder. My bladder bled like a waterfall. Okay, that's a Hunners lesion. I stayed overnight for what should have been a test because it wouldn't stop bleeding. When I was released the next day, that evening, my urologist called me the following day to see if it had returned. The urologist was the head of urology at a prominent hospital. At that time, the only answer was, due to the severity of my condition, was to remove my bladder. Being 30 years old and having 2 young children, I decided not to. All right, so Carolyn, when we think about genetics, we also have to think about subtyping, right? Because not everybody's the same. So my mother and my sister and my aunt and my grandma and my cousin were all at one point in time diagnosed with IC, right? So what is that? What is that genetic connection? And it was the University of Maryland who was the first to try to explore a little bit of genetics. So there are kind of 2 things that make sense to me. Okay, number one is nerve sensitivity. Redhead. I'm a redhead. We have tons of redheads in our family. Redheads are known for having quantitatively more nerves, and our brain actually processes pain differently than most other people. We are a double recessive gene. And so I was absolutely born with a more sensitive nervous system. So you take somebody with a normal nervous system and you put 500 cc's of water in their bladder, they can walk around for an hour or two before they need to pee. You put 100 cc's of water in my bladder and I need to go to the bathroom right now. Even though my bladder is perfectly healthy, the nerves inside of my bladder are sensitive. They have a lower threshold. That absolutely is inherited for me. But it also can happen after injury. So concept number one is that you have inherited a more sensitive central nervous system, which has made your bladder more sensitive, et cetera, et cetera. I've never heard in research of Hunners lesions being inherited. Let me check something here real quick. And I need to go get a glass of water. Okay, so here's a study that patients with Hunners lesions have a diverse set of neuroinflammatory genes that have a different expression compared to controls. They identified some gene expression. So that makes some sense. I will, let's see, hold on. This is a paper published. This is a really impressive paper from Cleveland Clinic. PI was Dan Shosky, who's renowned. It's actually a friend of mine. This was done by the Glickman Urological and Kidney Institute at the Cleveland Clinic. Oh, this was published last year, so this is very new. How did I not see this? How on earth did I not? Oh, this is why, because it's in a journal for andrology. That's why I did not see this earlier. So men with IC and Hunners lesions have a diverse set of neuroinflammatory genes with a differential expression compared to controls. We identify genes linked to neuropathic pain. Okay. Wow, that's fascinating. And that's fascinating. So obviously they're working on it, hon. They're working on it. I had not seen this study. And since it's not in a traditional urology journal, it's an andrology journal, and I don't subscribe to those. That's why. Fascinating. All right, now you're giving me another article I've got to write. Interesting. Okay. Caroline, where I was going to go with that was I also had to wonder if there was a chance that you guys were passing down perhaps a viral pathogen through generations. That was a guess. I would think that cyclosporin would be a very important treatment for you to consider, because cyclosporin, in fact, in the new AUA guidelines, they specifically state that cyclosporin should be recommended to patients with Hunners lesions who are not responding to other therapies. And cyclosporin is being considered a bit of a miracle drug for patients with very, very severe Hunners lesion disease. So you might want to look at that. So it's a hard therapy. It's a beast of a therapy because it comes with a lot of risks. But for the patients who have done it, and I have one very, very good friend who's done it, it's been absolutely life-changing. Mary on YouTube says, and hi, Sandy, if I didn't say hi to you before, how do you calm and soothe the bladder besides pelvic floor therapy involving stretching? Well, pelvic floor therapy doesn't calm and soothe the bladder. If the nerves in the bladder wall are being irritated, then we have to figure out what's irritating them. Obviously, tight muscles are certainly not helping, but this is where you might want to do something that has a soothing effect. You might want to do something that can kind of coat the bladder. We want to make sure you're not drinking a lot of coffee. I was working with a patient yesterday, well, the same patient I was talking about, who she called about apple cider vinegar. So she was doing 3 apple cider vinegars a day. She was drinking alkaline water, and she was drinking green tea every day, and she was in agony. And I explained to her that, listen, alkalinity is just as bad as acidity. When I was taking my very first chemistry class, when I got my first chemistry degree, and we were doing the safety procedures, and they were teaching us about the safety of acids like hydrochloric acid as compared to bleach, right? And the instructor said, well, bleach will eat your eyeballs out just as quickly as sulfuric acid. And I've never forgotten, that's what he said, bleach will eat your eyeballs out just as quickly as sulfuric acid. This is a really kind of gritty, fun lab instructor. And you know that when you spill bleach on your fingers, it gets slippery. Why? Because the alkaline bleach is dissolving skin cells. So you never want to go too alkaline, nor do you want to go too acidic. So Mary, let's make sure you're not accidentally irritating your bladder also. All right, hold on a sec. Hi, David. Katie, how often should you have a hydrodistension for Hunners lesions? My urologist said that most of his patients have it every 6 to 12 months. Well, I mean, that's really a good question. It depends upon what they want to do during the hydrodistension. If they're doing the hydrodistension to treat the lesion, such as with steroid injection or cauterizing it, then you would do it as needed. I would not assume that you would have to have a hydrodistension every 6 months for the rest of your life or every year for the rest of your life. Lesions are known for coming and going. And so the point of treating the lesion is to kind of close it, get it to calm down. And for some of you, the lesion never comes back. And if the lesion doesn't come back and your symptoms stay mellow, then you won't need another hydrodistension with treatment. But if your symptoms come back, then that means the lesion may have recurred. And that's when they might want to go in and do another one to treat it if it's particularly painful. You kind of have to, oh, hi, Joanna. Oh, you guys, I got to tell you about something, because yesterday I'm working on our new newsletter, and Joanna and Alfie are watching from Spain. So they are doing this fabulous course called the IC Retreat, where for a weekend, they are bringing in just a bunch of speakers to talk about many different aspects of pelvic pain, from diet, nutrition, to physical therapy, to various bladder therapies, basics on bladder. There's one doctor who's doing something called the IC Boot Camp. I can't wait to watch that. That's going to be very interesting. I'm one of the speakers. We've already filmed my course on bladder basics and subtypes. And so that's pre-filmed, so that if our power's out or if we are evacuated, they'll still have something that they can do for me. So anyway, that's going out in my newsletter, which I hope to send out tonight or tomorrow. And so make sure that you signed up for the IC Network newsletter so you can get all the details. The website is theicretreat.com. You're going to get $10 off the entry fee if you use the promo code JILL10, JILL 10. And it's really remarkable. I mean, the last time we've had such a big event on the internet was when I did it about 10 years ago. We did a big online conference. We did it for like 4 months. We had big speakers who came in every week. And I just haven't had the energy to do it. And it's just wonderful that Joanna and Alfie are doing this. It's going to be great. It's going to be over Zoom. You'll be able to participate from the comfort of your home. It's exciting. Very, very exciting. Amen. Information is power. The more information you get, the better. Hi, Denise. David said pre-leaf absolutely works, but gave you bad constipation. Interesting. I wonder what the mechanism of action is. I'm not sure. Denise says, I take one pre-leaf and it constipates me. I have IBSD. Interesting. Hey, Kayleen. I miss you too, hon. It's been very crazy here. Sylviane says, I was told my pelvic floor is weak, so she's working on that, which seems to be helping. Sometimes what happens, so like I can remember my first pelvic floor assessment was very, very interesting. We did it like 20 years ago. And what they found was that my levator ani muscles were super tight, super, super tight, because they were compensating for weakness in deeper muscles. When you have that pelvic floor exam, the physical therapist will put their finger in your vagina or in your rectum, and they'll ask you to do Kegels. You'll do a couple of Kegels, and what they're doing is they're just kind of testing how well your muscle is contracting versus relaxing. And so she asked me to do 5 Kegels. The first 2 were fine, but by the 3rd, 4th, 5th, I could feel that I could not release. And so therapeutically, it's important that they know that we've got areas of weakness. So generally what they're going to do is try to reduce the tension first and then start working on strengthening that muscle. You can't strengthen the muscle until you've gotten rid of the tension. Kayleen says, my surgeon is leaving to go to management. But she has a stud doctor replacing her. Okay, I see him to get my strings checked on the 20th. I'm going to get some educating papers for the detective, so hopefully that helps my case. Go for it, girl. Go for it. Denise says, I was getting a recurring UTI from menopause and ovary removal. Estrogen has been a lifesaver. Haven't gotten any since. Exactly, Denise. See? You are a genitourinary syndrome of menopause patient. That's exactly why. So I'm so glad the estrogen is working for you. Our challenge here is, for some of you, your doctor says, wow, you're dry down there, and they give you the estrogen, but you don't use it because you don't understand the importance of it. Or you might use it once and it might burn. And so you're like, oh, I'm not using this. I'm not going to use this if it burns. You don't understand that dry skin burns. You put anything on that dry skin, it's going to burn. So basically, there's like a 2-week period. You got to power through the first 2 weeks. And every time you use that estrogen, you produce more mucus, and slowly that heat and burning went away. Let me go get some water. I'll be right back. All righty. So you guys all remember that I had to take July off because my tonsils were swollen and red and painful. I got this infection on my tonsils, right? That's finally better, although they're still a little sensitive. But part of it was my fault because I was at night, I was sucking on, I had a lot of allergies because I sleep in a room with bookcases in it right now when the bookcases are dusty, and it just is what it is. It's just what I have to do. And so I was sucking on like a lemon drop, but not really acid lemon, but I was sucking on it to try to help with the nasal drip, not realizing that that was really badly irritating my tonsils. So it's like, not only do we have bladder sensitivity, but I have tonsil sensitivity. It was pretty funny. Rocio says, I had a cystoscopy that shows that I have mast cells. I think my bladder may be bladder wall driven. Is it possible that I also have pelvic floor? Sure. We don't know. They're both probably involved, but we have to try to figure out what's primary and what's secondary. You know, one of the ways that we used to describe IC is that it's like 100 mosquito bites at once in your bladder. And you know, when you get bitten by a mosquito, the venom gets injected, and it provokes mast cells to release histamine, which then cause irritation. And the more you scratch it, the worse it gets. And so if you, for example, have severe estrogen atrophy, that's kind of the same thing. Your bladder can't protect itself. Urine is getting in those areas where there's severe atrophy, and it's provoking exactly that same response. It's provoking mast cells to release histamine. That's why using an antihistamine is helpful for some, but certainly not all patients. Vicky says, get a standing. I have a standing desk. This is a standing desk. See? It's moving. Lori says the Graston technique is scraping. All right, hold on. Oh, by the way, we have a new diet study. Rob Moldman sent me the article, and I was going through it last night. Oh, I got it. Okay, okay. So scraping, imagine that this is metal with a specific shape. They can scrape it along the outside of a muscle to try to work on that muscle. I was thinking internal scraping. No, so I totally makes sense. So that's the Graston technique, and their website is grastontechnique.com. Donna said, I had a CAT scan done in July with IV contrast. I've had a flare for 5 weeks now. I went to my doctor last Thursday, put me on Gemtesa with the oxybutynin. With the oxybutynin I take, he also said I can have an indwelling catheter. What? 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 Said you can have an indwelling catheter. I've had 2 bladder augmentation in 1999, 2004. This one is closing up. It's shaped like a sideways hourglass. Don't know what to do but cry now. You went through 1 box of Azo. You're on the 2nd box yesterday. Has anybody had a flare from an IV contrast? It's rare. It's possible. But I'm surprised that it's lasted as long as it has, hon. I would expect that any of the irritation and or physical damage that the contrast solution would have done would have healed by now 5 weeks later. Like, I'm really concerned about your bladder closing. I mean, she say it's shaped like a sideways hourglass. I mean, honey, you've had 2 major bladder surgeries. You've had 2 augmentations. And so your bladder is not a normal, healthy bladder. You've had issues, serious issues with your bladder for, over 20 years. I think what's going to be the most important for you is to try to differentiate between, is this bladder wall driven? Like, are you of an age now that you are now in estrogen atrophy? And so because you're in estrogen atrophy, your bladder's more vulnerable. Okay, that makes sense. So if that's the case, that means that topical estrogen would be important, along with something like bladder rest. One of the supplements that contained chondroitin, bladder rest, bladder builder. Bladder builder finally came in, praise God, hallelujah, before the heat. So bladder builder has been out for about 2 weeks. It is now in, guys. It is in for anybody who is using bladder builder. We have plenty of bladder rest if you wanted to try the bladder rest. And I just put on sale Allopath. That's another viable option for soothing tissue. It's not going to fundamentally change tissue because aloe is a plant and our bladder is not made of plant material, but aloe has the potential of being soothing. And so Allopath is a combination of aloe with PEA, and we now know PEA helps reduce pain. And so if you've always wanted to try an aloe product, but it's just been too expensive, we just reduced the price by like $10. So it's $34.95 if you want to give it a shot. And it'll be on sale for a month, probably. I mean, we've got quite a few patients using it. They like it. But it's just not, when I think about estrogen atrophy and I think about the biology of estrogen atrophy, that we don't have that nice thick coating of mucus, my brain always goes to chondroitin first. Because chondroitin is a building block of the bladder wall. The bladder wall contains chondroitin. And we have one research study which showed that chondroitin was essential for the superficial integrity of the bladder wall. And so when I think about having a protective coating effect, my brain always goes to chondroitin first. But if you've got a really irritated bladder, there's always a chance that aloe might be a little bit helpful. Just like you put aloe on a sunburn, aloe on your bladder might feel a little good as long as you tolerate aloe well. Some people don't. Here, hold on a sec. I got somebody clicking.
Mama needs tea, she said.
It's in the hallway. Here, hold on. I'll be right back. Here's your tea. It's very hard on those days when I can't help them as much, like make a cup of tea. It's hard to put tea in the microwave when you got your hands on a walker. So they're working together, a 99-year-old and a 93-year-old, to make a cup of chamomile tea for my mom. And it's important that they work together. Also, Donna, could you ask for a rescue installation? How about a heparin lidocaine installation? I wonder if that would help you break you out of that flare. Worth the shot. Rhonda, what do you want me to explain, hun? I'd be happy to explain any question you have. Kayleen said, I had 3 days in a row with on and off consecutive peeing every 20 to 30 minutes. It's not as bad now, even though I drank a normal amount of water. It seems like it goes right through me. I do have an appointment with my uro on the 9th to talk about this. I think the hydrodistension I had last August was a waste because of the endometriosis all of my bladder. Do you think he'll recommend another hydro? I have no idea, hun. You've been through a lot. It might be a little bit too soon. Vicky says, the IV contrast always irritates my bladder, and they usually should warn you about it. They say drink lots of water after a CT, but you're way past that. Talk to the radiologist. Hi, Gay. Lori says, what's good to coat the bladder? Well, that used to be Elmeron, pentosan polysulfate. That was why Elmeron helped some people, not everybody, but it certainly helped some people because it has a coating effect. And in fact, I have right here one of the original education patient postcards. So this is a three-dimensional picture of your bladder wall. So we've got your nerves and blood vessels down here. We've got your urothelial cells here. And then we've got this nice thick coating of mucus. And you can see that the mucus keeps the irritants in your urine from reaching these cells. But if that mucus is missing, the irritants in your urine come right back down and reach these cells. So unfortunately, Elmeron is now linked to retinal disease. And so there's no other medication, FDA-approved medication that has that coating effect. And so you've got two options. And we have an Elmeron transition guide on our website. Option number one is you could have an Elmeron installation or a heparin installation where they put 100% of the medication directly in your bladder. That's a far more effective way of using Elmeron, because if you swallowed a Band-Aid, do you expect it to come out the other end of Band-Aid? And the answer is no. We have digestion. And the bioavailability studies for Elmeron show that like 92-93% of it is rendered inactive by digestion. So when you take Elmeron by mouth, only 7%, 7 or 8%, some doctors argue less, actually arrive in the bladder to do anything. And of course, you have to take a lot of Elmeron over a long period of time to get a sufficient coating because that bioavailability appears to be quite low. So in contrast, if you do it as a bladder installation, you're putting 100% of the medication directly in the bladder. That is a far more effective way of delivering Elmeron to the bladder. And because they believe that it stays in the bladder wall, that seems to be less risky with respect to your eyes than taking it orally. So again, you could go to a bladder coating that's done as an installation, either a heparin lidocaine installation or an Elmeron lidocaine installation. Or you can do a chondroitin-based supplement. I should say this, if you're in Europe, there are other coatings you can use that are not approved in the United States. Uracyst is a chondroitin coating. Cystitis is a sodium hyaluronate coating. Ialuril is a combination of the two. Those are only available in Europe and Canada. They're not available in the United States. So in the United States, we're out of luck. So your next bet is to do, again, a chondroitin-based supplement like Bladder Builder. And this is just our best guess. You know, at least we've got options for you. You know, that's the blessing today rather than 20 years ago. The blessing today is that we have a lot of other options that you could try. Is it going to work for you? Nobody can say it's going to work. But it's working for some patients, not working for all patients, but it's a viable option. Suzanne says, can IC go away permanently? Well, Suzanne, the better way to ask that question is, can pelvic pain go away permanently? The answer is absolutely. We have to figure out what's causing it. So if you have, for example, a chronic UTI, we can treat that chronic UTI. If you have pelvic floor dysfunction that's causing your pelvic pain and your bladder symptoms, we can treat that and it could go away. If you have Hunners lesions, well, that's a bit of a different beast. Hunners lesions are far more difficult to treat, although once you treat them correctly, they respond beautifully. But there are things about Hunners lesions that we're still trying to understand. And so this is what we know. Again, if you look at the AUA guidelines, they say a one treatment fits all approach does not work. Why? Because we're not all the same. For some of us, IC began in childhood. For others, IC began after menopause. Are we biologically the same? No. For some of us, IC began after chemotherapy or drinking way too much diet soda, while for others, IC began after having a baby or falling on their tailbone. Are we biologically the same? No. IC is a grab bag diagnosis. You get a diagnosis of IC when the doctor says you got frequency urgency pressure pain, but they don't really know why. So now we very clearly understand the diversity in this patient population. We're not all the same. Bladder therapies don't work for a lot of patients. Bladder therapies never worked for me. Why? Because my bladder is healthy. It's my muscles that are the problem. What worked for me was physical therapy. So it's about understanding the underlying cause of your symptoms, aka your subtype. Nicole says, I wanted to share my urinary health kit that I bought from my urogynecologist. It's called TheraWorks. It comes with a month's supply of feminine wipes and foam that clean with a highly something something. Huh. Let's look at it. TheraWorks. I'm always looking for new things. Always. Muscle cramp spasm relief. Hold on. What is it? A month's supply of feminine wipes and foam that clean. So it looks like TheraWorks is for muscle spasms. So it's a muscle cramp and spasm foam. Interesting. Wonder what it's made of. Let's see if we can look at the ingredients here. So they give you a compression glove and the foam to use. That looks very interesting. Thanks for sharing that. I'd like to know what the active ingredient is. Is there a way of getting to the active ingredients here? Magnesium sulfate, water, cocamidopropylbetaine, aloe juice, colloidal silver. I don't know why that would be in there. Grapefruit extract, glycerin. Oh, it's got parabens. It's got methylparaben, propylparaben. Ew. You might want to, there are a lot of products that provide cramp and spasm relief. Like I love Tiger Balm. And some physical therapists have created their own. I've got one from one physical therapist somewhere. I don't know where. You might want to ask around for anything else because this has some pretty controversial ingredients in it, hon. Mary says, oatmeal, I have been eating every day for 2 weeks and I've been peeing every afternoon, got worse, pain peeing. Could it be? Yeah. I will tell you that I've worked with many patients who are oatmeal intolerant. And they're always surprised when I say, hey, I have that too. And they're like, really? I thought I was the only one. I can remember making oatmeal cookies as a kid and getting really sick from it. Alexa says, if he didn't diagnose me with IC, why did he give me muscle relaxants? He diagnosed you with mixed incontinence. Well, mixed incontinence might be caused by dysfunctional muscles, some of which might be tight, others of which might be weak. You don't use the term IC. That's misleading. If he didn't diagnose me with pelvic pain, why did he give me muscle relaxants? Understand that the muscle, muscle tension is playing and muscle dysfunction is playing a huge role in all of this. IC, vulvodynia, urethral pain, prostate pain, rectal pain. One of the connecting factors is dysfunctional muscles. I'm glad that he gave you the estradiol cream. That's good. UPAC, Nicole says UPAC is the cleaner. I don't see it on their website, hon. Is it by the same company? UPAC? No, not on their website. All right. So it's getting real hot here now. I'm gonna start getting real antsy real soon. Gonna be 100 over 110 tomorrow, over 110 on Tuesday, 108, 106. It's gonna be well over the hundreds for the coming week. Wow. Alexa says, should I ask for pelvic floor therapy? If your muscles are tight, you absolutely should ask. The new AUA guidelines only have two recommendations. Recommendation number one is if that patient has tight pelvic floor muscles, you get them to physical therapy immediately. And if that patient has Hunners lesions, you treat the lesions immediately. No more of this waiting 6 months or a year or 2 years, 3 years to treat Hunners lesions. The number one cause of severe pain, the most severe pain in the ICU world, are patients with untreated Hunners lesions. It's heartbreaking. Here you're having a hydrodistension. The doctor finds it, but he doesn't treat it. Why would you waste that opportunity? You don't want to waste that opportunity. This is why, if you're ever going to have a hydrodistension, one of the questions you have to ask is, if you find a lesion, what are you going to do about it? How do you propose to treat it? How do you intend to treat a lesion? And if they say, we're not going to treat the lesion, you're going to say, why not? The AUA says you're supposed to treat the lesion immediately. And they might say, well, we don't have the equipment to treat it. You're going to say, okay, who has the equipment to treat it? If they don't treat it at the time, it is inevitable that you will have to have a hydrodistension again. That means you're undergoing, you have to pay for it, and you're undergoing the risk of surgery again, the risk of anesthesia again. So the rule here is if you have a hydrodistension and they find a lesion, they're supposed to treat it at that time. And if they don't have the equipment to treat it, I personally wouldn't have it done there. I would ask, all right, who can treat it? We want to maximize your care. There's nothing more tragic to find somebody who was diagnosed with lesions 10 years ago and they've been suffering for 10 years because those lesions were never treated. It is infuriating. Lesions respond beautifully to lesion treatment. We have one study that showed that 100% of patients got better. Other studies are at 90%, 92%, 88%. But lesions respond beautifully to lesion-specific therapy, which is cauterization, fulguration, laser therapy, steroid injection, or maybe hyperbaric oxygen therapy. So, hi, Loretta. Lauren says, do you know how long an Elmeron installation would last in the bladder? Years ago, as we were talking about the pharmacology of Elmeron, at some point in time, somebody said that the Elmeron molecule is very small. Thus, it takes a lot of Elmeron molecules to kind of fill in a hole in the bladder, for lack of a better term. So what they implied, and don't ask me to find the source, this was years and years ago, I don't know if I could ever find the source. What they were saying is that because of its smaller size, Elmeron doesn't necessarily stick well, that it's easier to flush out. But again, don't quote me on that. I don't think I could ever find that. That was a long time ago. That's a challenge here with this image, is they're implying it's a liquid coating, but it's actually, I mean, it is a liquid, but we need to know the distribution and the size of the molecules in the liquid, right? It's not like there's a giant molecule that fills in a hole and attaches there permanently, right? It's a solution. Rhonda, and Lauren, I kind of want to say something about dwell time here. Again, if you look at the new AUA guidelines, I think what they said in the guidelines is a DMSO is usually held for 15 minutes and before you pee it out, and that the rescue instill, the heparin lidocaine installation, you know, the goal is to try to hold it for an hour before you pee it out. I think that's what it said. You can go look at the guidelines and read them yourselves too. Rhonda said 20 years more ago, Joe, we would have grabbed anything. Yeah, absolutely. Donna said he wanted me to try Gemtesa and Callista as steroid. I need relief now. All he said is my bladder is very small. My last installation was 2004, and you had Hunners lesions burn out. Honey. I mean, have they looked in your bladder? When was the? I mean, you're saying they haven't looked in your bladder since 2004? And I apologize, you know, guys, I'm just reading lots of messages here. Don't be offended if I miss your message or don't answer it. Just ask it again, because it scrolls by quick and then I miss them. Jennifer said she had her lesions biopsied last week. You're still in pain? Yeah. So Jennifer, it's very important that you really protect your bladder. Diet matters right now because you have a physical injury in your bladder at the biopsy site. Hopefully it's starting to heal, but the bladder is the slowest healing organ in the body. So it's going to take a couple weeks for things to really calm down. Sarah says, what about trospium? Well, let me refresh my memory. Oh, it's an overactive bladder med. Well, it's not approved for IC. It's approved for frequency urgency / overactive bladder / bladder spasms. So if you have bladder spasms, it would be viable. But if you have estrogen atrophy, if you're having bladder spasms because you have estrogen atrophy, because irritating urine is getting down to the nerves and triggering the overactive bladder, then trospium's viable. Lori said, I was told my bladder had a small capacity to hold urine after your hydro. My bladder has never been a normal size. My bladder has always been like 2/3 of the normal size. Rhonda says she's oatmeal intolerant. Jennifer says oatmeal intolerant, so painful. Alyssa says, my doctor told me to stop Elmeron. It's recalled because of blindness. It's not recalled. It just has a warning, a very serious warning on it. Elmeron, you know, I am unfortunately that person who broke the news about this new research from the Emory Eye Institute, where they found that Elmeron appeared to cause a retinal disease that they call pigmentary maculopathy. It basically changes the color of the cells of the retina. And I have, let me see if I can find this here. Oh, here it is. So it's actually, I think 4 years ago. 4 years ago on a Labor Day, I didn't have anything else to do. So I was actually sitting here at this desk looking for articles for my magazine. And I was going through the National Library of Medicine. And I found this letter to the editor that these doctors at the Emory Eye Institute had written to the Journal of Urology, trying to let urologists know that they believed that they had found a bladder disease caused by Elmeron. So let me read this to you. I think this is actually the original letter to the editor. It says, we wish to alert readers to a concerning new observation of vision-threatening retinal changes associated with the long-term exposure of pentosan polysulfate, which is actually Elmeron. We recently reported our findings of retinal pigmentary changes in 6 patients undergoing long-term therapy with Elmeron. They experienced difficulty reading, trouble adjusting to dim lighting, among others. Although we have yet to establish causality, the presence of these highly unique retinal findings in this population demonstrates a strong association with long-term Elmeron exposure, pentosan exposure. So this was mind-blowing. I mean, I'm telling you right now, I started bawling. I was like, oh my God. Oh my God. So then I went and I paid $40, $45, or however much it was, for the paper that they published in the ophthalmology journal. And of course, urologists don't read eye journals, just like the eye doctors don't normally read urology journals. So then I went and got this paper. And this is something called a case series. So this is not making any statements about how many people have issues. I'll get to that. This is just basically sharing the results from 6 patients. And age 62, 60, 46, 60, 60, 37. And they were all referred to the Emory Eye Institute because they all had changes in their vision. And so these are some of the pictures that they shared. And so these are pictures of the eye damage worsening over time. So this is like at the first appointment, this is a bit later, and then this is later, and you can slowly see this changing. There's even better pictures. This is an even better picture, right? And so a very small change here, and then look at how much more of the retina is involved. Here we have a lot of small visible changes that have become a much larger area that's damaged, and now more. So you can really see this changing over time. And I think one of the ones that's the most important is, and so here's another picture. But these scans down here, this is a 3-dimensional picture of the eye, of the retina. And this is where you can really see changes in the retina. All right. So, you know, I was sitting here going, holy moly, what? Because we'd never had any discussion of anybody of eye issues with Elmeron. I mean, I've been working with patients from before Elmeron was approved in '96. So anyway, make a very, very long story short, I emailed some of the top doctors in the country and said, let's credibility check this. Let's do a survey. Let me do a survey. I've got 30,000 IC patients on my database. Let's do a survey and let's see. Because I fully thought that our survey would show that it wasn't a connection. Well, our survey was stunning. I haven't looked at it recently, but I have 2,000 patients in our IC pigmentary maculopathy Elmeron study. 54% self-report retinal disease. Now, of course, that cannot exclude hereditary issues. So obviously, doctors running eye clinics and urology clinics started doing their own studies, and they validated it. there is absolutely a clear connection between the use of Elmeron and retinal disease, so much so that the company put a warning about it on the drug information. And the new AUA guidelines have a very specific statement on it that before you are to be given Elmeron, the doctor needs to talk to you about, do you have any history of retinal disease, any history of eye issues? If you do, you're supposed to go have a retinal exam before even starting Elmeron. And then if you do start Elmeron, you're supposed to have a retinal exam within the first 6 months so that you've got a baseline idea of what your retina looks like. And then subsequent follow-up retinal exams to make sure your retina isn't changing. What they were concerned about in this original letter to the editor, and let me just read what they said here. Pending further investigation, it remains unclear whether drug cessation will halt or alter the course of retinal disease. You understand what they're saying here is they didn't know if stopping the medication would stop the eye damage. And there is a very interesting case published by an ophthalmologist at Harvard who had a woman come in who had severe retinal changes on one side. They did the complete workup. They couldn't find any explanation for it. And the diagnosis was that she had a toxic maculopathy, perhaps from some sort of chemical exposure, right? And so they sent her on the way, said, hey, you were exposed to something, and that's why you have an eye issue. Well, the patient came back several years later, and it was in her other eye. And they did a complete workup, ruled out genetics, ruled out inherited macular conditions, and they had exactly the same conclusion that it was a toxic maculopathy. Their best guess was that their eyes were being affected by some sort of toxin. Well, shortly thereafter, the Emory researchers released their paper, and that ophthalmologist at Harvard remembered of this patient and went back into her records, and yes, she had been on Elmeron. And so that became her diagnosis, that she had pigmentary maculopathy. But here's what's important about that case study. She stopped the medication the first year, but 6 to 7 years later, it was in her other eye and progressing. Now, we don't know if that's true for other people. There's still a lot of research to be done. But this is why, we have to, I believe in informed consent. I knew that I would change the IC world when I shared this story, but I couldn't hold it. I couldn't hold it back. I believe in informed consent. You had absolutely the right to know that a medication that you were taking could possibly lead to blindness. And so I made that decision to share that information with the IC world and to do our study and to send our information to the FDA. I was told by one of the top doctors in the country that our research was excellent and that we should send it to the FDA for their consideration for a warning label. So it's a big deal, hon. It's a big deal. I have over on the IC Network website, and I have a transitioning from Elmeron. I have a pigmentary maculopathy information page with all the research. And then I also have an article on transitioning from Elmeron to other things. Patients have been, the challenge with Elmeron before this was that the cost went up so high that patients simply couldn't afford it. Even if it was helping them, they couldn't come up with the money. And so patients had been transitioning off of Elmeron for cost reasons for many, many years. And generally, they transitioned over to a chondroitin-based supplement. I finally figured out why my head itches. You know why? Because my hair is so long, when I lean back, it pulls. It's not itching, it's my hair being pulled by my chair during these meetings. Normally, I have my hair up. but I usually have it down for these meetings. Oh, Donna says, has anybody had an indwelling catheter as a tube like a catheter installed in your right side? And if I don't like it, I can have it removed and go back to being normal. He put me on at home working because car rides kill me now. My husband wants to retire and quit. I'm 63, have to wait till I'm 65, and I've worked there for 22 years. Yeah, it's hun. So you already have it? Do you have the indwelling? I mean, indwelling catheters are wonderful. I mean, because it basically is you're bypassing your bladder. You're bypassing your bladder, and your urine can drain into a bag or whatever system that they've developed for you, and that can dramatically improve somebody's mobility and ability to work. And then you're giving your bladder some time to heal, maybe a couple of months. They can reverse it. It's not commonly done, but it is certainly a viable option for some patients. Elaine says, can actual UTIs have damaged my bladder wall? Yes. Can UTIs cause tight muscles? Yes. Can UTIs irritate nerves? Yes. The question is, are they real UTIs? Yeah, I'd be amazed at the number of people that I work with who say, I've had UTIs for years. And it's like, okay, what's the bacteria? Have they identified the bacteria? And they go, no. You have to remember the bladder only knows one language: frequency, urgency, pressure, pain. Everything feels like a UTI. A bullet wound would feel like a UTI. Stab wound would feel like a UTI. Chemotherapy would feel like a UTI. That's the only way the bladder can tell you there's a problem. Injuries can feel like a UTI. Genital urinary syndrome of menopause can feel like a UTI. Cranberry juice it would irritate your bladder wall and it would feel like a UTI. And for most of you, the patients that I work with, there's no infection. And that's like, okay, when did you last have a positive culture? And most of them say, I can't remember. Some of you say, yeah, I had one 6 months ago or 3 months ago. So Elaine, I just put a new blog up on the IC Network website on UTIs and how to differentiate between a flare and a UTI. And then kind of some of the current thinking about UTIs in the IC patient population. I think IC patients are going to be more vulnerable to UTIs. For those of you who are doing catheterization, bladder installations, things like that, that's going to definitely increase your risk, because anytime you put an instrument in the urethra, you're pushing bacteria up into the urethra. Loretta says, most likely people intolerant to oatmeal is because it contains the protein avenin. The protein is the problem. Loretta, girl, you're knocking my socks off here. I never knew why. Oh my God. I mean, it was so long ago for me. I haven't read about it recently. Here you go, Wikipedia. Oat sensitivity represents a sensitivity to the proteins found in the oats, Avena sativa. Sensitivity to oats can manifest as a result of allergy to the oat seed storage proteins, either inhaled or ingested. A more complex condition affects individuals who have gluten-sensitive enteropathy, in which there is an autoimmune response to avenin, the glutinous protein in oats, similar to gluten. Wow. I mean, I understand that the proteins are the issue. It's been so long. I haven't really read about it. Studies on farmers with grain dust allergy and children with atopic dermatitis reveal that oat proteins can act as respiratory and skin allergens. Oat dust sensitivity in farms found 53% showed reactivity to dust, second only to barley, and almost double that of wheat dust. Food allergies to oats can accompany atopic dermatitis. And wow. You know, what's interesting about this is they're also talking about cross-contamination. And back when my IBS was really, really bad, you know, back in my 20s when I was dealing with these spasms every day, um, my sister gave me a book, which I still have. Where is it? Here it is. I mean, realize that I did not understand what was wrong with me. I had no freaking clue. All I knew is that I was not normal. I had terrible bowel issues in my 20s. It was really bad around Christmas. Every Christmas, I mean, like I ruined Christmases several years in a row because I was so sick. And everybody's like, "What's wrong with Jill now?" And it's like, I didn't know what was wrong with me, right? Well, my sister, Janice, who might be listening, Janice, I love you. You changed my life when you gave me this book. The Best Guide to Allergy. They don't even make this book anymore. And this is the book that started talking about, it's the first book I read that talked about food sensitivity, food allergy and food sensitivity. And so what did they say? They said, well, the number one thing that you immediately remove is dairy. So I had already gotten rid of all dairy. I hadn't eaten dairy for years, like 3 or 4 years. And then in their elimination diet, they said, okay, stop all the grains but rice. Stop every grain. I'm like, okay. I stopped all my grains, and the next day, I did not have bowel spasms. Night and day. And then what they did is they said, okay, now you need to reintroduce a grain one at a time to try to figure out the grain that bothered you. And it was the effing oats. I was putting oats on everything. I was putting oat bran on my salads. I was eating, oh my God, I was eating oatmeal every day, not having a clue. Then the other thing that this book talked about is, why was I always so bad at Christmas? And I was shocked to see this. What about Christmas trees? Christmas trees cause allergic symptoms in many people. The most common sources of difficulty are airborne pollens and molds that are in the trees that remain there after they've been cut down. A person who is sensitive to these pollens and molds who come into close contact with them will come into close contact when the tree comes in the house. The heat of the house helps to release the inhalant substances into a closed indoor environment. Thus, the family recreates specific pollen and mold season for a few weeks in December. And that's terpenes. It was the effing Christmas tree too. So I literally, like a day or two before I got this book, I just bought a Christmas tree, threw it out, went and bought a artificial tree, and I haven't had Christmas illness ever since. Janice, you have no idea what you did for me. I do not know if I would be here if you had not given me this tool that helped me figure it out. I mean, you know how sick I was. If I hadn't had this, I probably wouldn't be here. It was so bad. So thank you. I love you so much for how much you helped me. You are an amazing sister, and I'm very blessed to have you as my sister. All right. And guys, she really helps the IC network. Let me tell you, we work together. Okay, Elisa, I was really worried. I've been taking Elmeron since my late 20s to current. My vision has gotten really bad. Had an optometrist check my eyes and they look okay, but I'm worried. Well, honey, an optometrist is not going to check for this. You have to go have retinal procedures. You have to see a retinal specialist, not an ophthalmologist. So it's not the same type of doctor. Yeah, so you need to go have a proper retinal diagnostic workup. Rhonda, thank you so much for the 530 stars. Thank you, thank you, thank you. I have no idea how much that means right now. This is, in the lifetime of the IC Network, 29 years, this is the first year where It's hard. Rhonda says Avena sativa. I wonder what else is in. Makes you wonder. Sarah said, are there proteins and then that can affect the bladder? Because whenever I have minestrone, I meal for my bladder. Honey, it's probably the tomatoes. I'm going to guess that it's the tomato sauce that's in the minestrone, and or if there's black beans in it. Black beans can be really irritating and acidic. Rhonda said, who's that book by? Well, there's a lot better books now on allergies. I mean, you could just Google it. This was made by the Consumers Union in Mount Vernon, New York. Published by Appleton Century Cross. But you can just Google oat sensitivity, Christmas tree sensitivity, life-changing book. You know, it's interesting. I've asked doctors, it's like, I didn't have a problem with Christmas trees when I was a teenager. Why did it happen in my 20s? And they said that's the way it manifests for some people. Is sometimes these sensitivities really kick in your 20s. So learning about what you're intolerant to is so important. Alyssa says, so chondroitin supplements help? I think I spelled it wrong. I've been getting that installation for over 10 years. Yeah, hon, they do. You've got Bladder Builder, which I believe is the best chondroitin supplement on the market. Bladder Builder contains chondroitin for the bladder wall, quercetin as an antihistamine. It's got some beneficial probiotics for the gut, and it's got PEA in it for pain relief. And but if you flare when you eat yogurt, then we would say don't do Bladder Builder, do Bladder Rest. Bladder Rest is kind of the perfect starter formula for somebody just trying it out for the first time. And of course, any supplement on the market has the potential to cause side effects. Generally, the chondroitin supplements can cause some loose bowel. So we always say, if you're going to try it, take one and wait 24. Take one with food. Never take it on an empty stomach. Wait 24 hours. See how you feel. Do one a day for a week. See how you feel. Then you can go to 2 a day for a week. Go to 3 a day for a week. I'll tell you that when the old chondroitin supplement, Cysto Protect, was invented over 20 years ago. These are newer. These are in the last 5 years. When I took Cysto Protect, I could do 1 a day, but I could not do 2 a day or 3 a day. Really messed my bowels up. And now I know that my bladder's fine. So I personally don't need to do a chondroitin supplement. I do Peora, Peaora, just to keep my nerves calm. And do I even have that? Let me go get that bottle. Hold on. All right, let's just for those of you that are interested, let me just give you a little lowdown here. And it's getting really hot here, guys. I gotta put my hair up in a ponytail. Give me a quick sec. We're going into our Flexler in 45 minutes, which means I'm gonna have to turn everything off. So to try to avoid rolling blackouts for the heat, which I'm sure we'll be having tomorrow. Okay, so the original supplement, although it's gone through many labels, is Cysto Protect. This is a new label as of last year. Cysto Protect was invented by Dr. Theo Herides, a federally funded ICU researcher, a good 20 years ago. And he was doing, the state of Massachusetts was asking him to do some safety testing on supplementation, because he's a real I say this in the best possible way because I'm this way too. He's a geek when it comes to pharmacology, and so he loves the science. So he was like, yeah, I'd be happy to do that. And so as he was learning about these various supplements, because he'd already worked with IC, he was like, I wonder if we can create a formula that might help an ICer. So he created Cystoprotect, and then he did a very large study of over 250 patients who used it for 6 months. And if I remember in that first study, like 57% of patients reported a significant reduction in their pain, and especially the patients who had more severe IC. And that was published in the Canadian Journal of Urology. Not quite the top tier journal, but still it was enough to get through their peer review. Well, he sold the license for Cystoprotect away to other companies. So Alevin had it first, and then Meta Consumer Health bought it, and then Mylan bought it, and he had to sign a non-compete agreement, so he could never update it. And so we've learned a lot about IC in the last 20 years. And so the next supplement was this one. So Cysto Renew was created by Dr. Gio Espinosa, who ran the integrative urology department at NYU. And so this was the first supplement that had the chondroitin, but he also included a little bit of lemon balm, and lemon balm is known for calming nerves down. And we had learned a lot about neuroinflammation in IC. So that was kind of a genius move here. So he put a lemon balm in it. Now that's not citrus lemon. That's a mint with a lemony scent. There's no citrus in it. And then he also put a little bit of aloe vera in this one. So Cysto Renew was kind of the next generation supplement 10 years ago. So a lot of patients transition from Cystoprotect to Cysto Renew, but some patients really still love Cystoprotect. Well, then about 5 years ago, Natural Approach Nutrition came along, and that's a very interesting story because this was a CEO, had terrible pelvic pain, and he reached out to me and for help. And I had no idea who he was. I just got an email from a man who was suffering, and I wrote a really long email back. And over a couple of years, managed to really help him and get him connected to some really good doctors. And one day he said, "How can I help?" And I'm like, well, he said, "I need to tell you who I am." And I said, "I don't need to know who you are. It's fine." Well, it turned out he was the CEO of a lot of companies, and he had a lot of experience and a lot of connections. And he goes, "Jill, you help me. I want to help you guys. What can I do?" And he told me his background. And I said, "Well, how about a next generation supplement? Can you take a look at what the research is now, what we've learned about IC, and let's see if there's something new that can be created." And the byproduct of that work was Bladder Builder. And Bladder Builder is today, in my opinion, the best supplement on the market because it has the most methods of action. It has more ways that it can help you than any other supplement. So it's got chondroitin for the bladder wall. It's got quercetin as an antihistamine. It's got some L-arginine in it, which research studies have shown helps to support urination. It's got some essential vitamins in it. It's got some probiotics in it for the gut. That he was very insistent on that. But my contribution to this was PEA, the addition of PEA for pain relief. So this one very quickly became quite popular in the IC world, and it's still probably the most popular supplement. But it's a very bold, robust formula. And for people who are uber sensitive, who don't like to try new things like me, or for people who flare when they eat yogurt, I said, this is a little bit too strong. Can we do something that's very mild for people who are more sensitive? And so they created Bladder Rest. And this was about the time that Cystoprotect was unavailable for a year because of the cancer warning, the old cancer warning with that product. And so bladder rest is a good starter formula. The other thing I asked him if he would do is if he would create a low acid multivitamin for us. We had been originally, that was my idea. I had a CEO of FAR Laboratories ask me years ago if you could create anything for an IC, or what would you create? And I said, I know exactly what I'd create. I'd create a low acid vitamin, because every day I had patients asking for bladder friendly vitamins. We didn't have any. So they created a low acid vitamin called Multirite. Now, the problem with Multirite is that it's a huge pill and it's hard to swallow. I had to cut it in quarters to swallow it myself. And so I asked Natural Approach Nutrition if they would take a shot at creating a low acid vitamin that was much easier to swallow. And this is fabulous. This is what I use. It's fabulous. And the same thing too, when we had the PEA research, the PEA IC study from Europe, that showed that 87% of patients struggling with pain had a significant reduction in their pain when they used palmitoyl ethanolamide. And we couldn't import the European formula, so we asked him, can you create a formula made in America that's similar to what was used in that study? And he created Pura. And this is what I take. People ask what I take. Now, my subtype's different than yours. I don't need to do the chondroitin for the bladder. My number one goal is to calm the sensitive nervous system down. And this is fabulous for me. And then last but not least, aloe. Aloe has a soothing effect. You put aloe on a sunburn, it helps. Well, aloe in the bladder has a potential of kind of calming and soothing the bladder. But he added PEA to it to enhance that soothing effect. And so I think that this aloe product is really a great aloe product. And I just put it on sale for $34.95, like marked down $8, $9, $10, whatever the original price was. So those are our supplements. And the blessing here, is that the AUA guidelines have said, please try the supplements before you try the traditional medications, because these don't have the side effects of the Elmeron or of the Elavil or the hydroxyzine. And so if you look at the AUA guidelines, they encourage the use of supplements because they come with far fewer risks of adverse events. And so we're very blessed that we now have a very robust lineup of supplements that might be helpful. It might and it might not, but we're all individual, and it's just got to look at your sensitivities and if you're sensitive to any ingredients and all that sort of stuff there. Okay. P says, what can I take while pregnant? Nothing. We have a pregnancy resource center on our website. You can go over there, go to icnetwork.org and go into our pregnancy resource center. We only have one study that's evaluated traditional medications with respect to their risk to the fetus. And you're going to have to buy that article from the journal. I don't have that article to sell you. I don't have it to give to you. We're not allowed to do that. But we have a link to it. That's the only study that has looked at the risks of various IC meds to infants, to a fetus. I will tell you, in the study, the one medication that they thought was the safest was Elmeron. But now that we have these issues about the eyes, I'm going to say that that's going to have to go back down on the, it would not be something I would want to be using while pregnant, just if on the off chance that it might affect the vision of a fetus. We just don't have that data to say that that could happen one way or the other. That's why generally they tell you not to use anything, when, especially in that first trimester. Joanne says, my sacrum's been pulled forward and off to the right, which has been causing a lot of pain for me. This was from my bladder prolapse repair surgery, which now is a grade 2 prolapse. Wow. So they repaired your prolapse so tight that it's pulling your sacrum out of position. I believe it. It's possible. I mean, it's unusual. I mean, well, okay, let's take that back. So let's look at our model here for a moment. Here's the spinal cord and our vertebrae. This triangular bone right here is the sacrum. And at the bottom of the sacrum, we have the tailbone. So what you're saying is your sacrum is pushed inwards and to the right. And unfortunately, this model does not show. I mean, we can see we've got muscles right here that are attaching to the sacrum. That's why, you know, a broken pelvis, broken sacrum, broken hip bones after injuries are a beast. I really hope that they're able to fix it. Are they able to fix that for you, hon? That's, as somebody who has SI pain, I feel for you because I have SI pain too. I will say, at least for me, and I've told this story many, many times, it was getting harder and harder and harder to sit and work. And I always had pain in my left SI joint, although I didn't know it was my SI joint. For 10 years, my doctor said it was a damaged muscle. And it took another physical therapist who figured out that no, it was my SI joint and it was an injury to my SI joint. Once I put a small lift in my right shoe to balance out my legs, a lot of my pain went away. Like I used to have SI pain every day. I go weeks and weeks and weeks without any pain. And I'm walking like a beast now. I am working out like mad. And it's every now and then it'll twinge me, but it's really helped a lot. Just getting my legs the same length so that we're not putting any pressure on the bones and the muscles. Brian says, I'm starting insulin treatments Thursday, quite nervous as a cystoscopy left me in agony a few months ago. Insulin treatments, insulin. Hold on. We have to deal with the different names for medications in different countries. So insulin, INSTYLAN. Okay, this is Canada. Approved during COVID, September 2020. Oh, okay. This is the hyaluronic acid. So this is like Cystitis. I don't, you know, hon, I think the biggest part for you, I can't see the medication hurting because Cystitis has been used for decades in Canada. Sodium hyaluronate or hyaluronic acid is a building block of the bladder. And so there's nothing that I can see that would be irritating about the installation unless you happen to be sensitive to another ingredient like the lidocaine. I think the challenge, Brian, is you have a very long urethra. Unlike women, you know, our urethra is like 2 inches long. Yours is like 6 inches long. And so it takes a long catheter that goes up the urethra, past the prostate, into the bladder. And so normally for a guy, it's not necessarily the medication, it's the freaking catheter that is causing urethral irritation. And normally the way we would see that is after the procedure, the first couple of times you urinate, it can be agony. And you sit there and you kind of stop and start and stop and start. And it goes away usually within 48 hours, but that urethra has been traumatized by that catheter. And that's what we see, but it does go away. All right, let's come back to Facebook here. Sarah says, what about chickpeas and white beans? They should be fine. I got a bowl of chickpeas right now in my refrigerator. White beans are fine. Katie says, does bladder builder affect Hunners lesions? I tried it and it burned me. No, there's no supplement that has been found to be effective for Hunners lesions, just like there's no oral medication that has been found to be effective for Hunners lesions. Some medications might help soothe some of the symptoms, but Hunners lesions require lesion-specific therapy. That means they've got to find the lesion and they got to poke the lesion directly. They're either going to inject it with a steroid or they're going to cauterize it. And once you treat the lesion correctly, the pain usually goes away in like 85, 90, 95% of patients. But if the thing is that a lot of doctors and a lot of patients are just like, well, I just want to do oral meds. Well, oral meds will never get you where you need to go with a Hunner lesion. Hunner's lesion, we have to deal with the lesion in the bladder. So there's no oral treatment, nor is there a supplement that's going to help a Hunner's lesion. The only exception that I would make is because we do have research that has shown that for some people, Hunner's lesions may be viral. And if you have a viral test and they find active virus, then you might be able to do lysine, which helps to inhibit viral replication. But that would be a waste unless you had the viral test. Jackie says, any insight on CBD oil for bladder pain or inflammation, hun? We have the longest serving medical marijuana CBD paper survey in our survey center. I think I finally shut it down like 2 years ago. We did it for over 10 years. Yes, many patients do use medical marijuana or CBD effectively. You just have to be very careful on what you pick. You always have to get safety data with each lot. Our biggest challenge with medical marijuana here in California is that a lot of it is compromised with pesticides and fungicides. We had a very important case down in LA, Los Angeles, of a man who had a severe back injury. He was using medical marijuana very successfully. And then when he went and got the new medical marijuana, same brand, same company, he felt like he was being poisoned. He had a really bad reaction to it. And so he personally sent it off to a lab, and it was massively compromised by pesticides, like he was being poisoned with pesticides. So he sent it to a TV station, to a consumer guy on a TV station, and said, hey, you might want to know about this. So the the TV station did wide-scale testing from many medical marijuana distribution centers, many brands, and did the testing. And guess what? Most of it, there's only a small group of producers where there was no pesticide contamination. The rest were massively adulterated, even organic. And so the rule of thumb, what we learned from that, and this was probably 6, 7, 8 years ago, is that if you're going to get medical marijuana or CBD, if it's medical marijuana CBD, you have to get the lab results. You want to look at that first. If they do not have lab results guaranteeing the purity of that product, I would not buy that product. Wouldn't trust them. I would not trust them. Because you have to understand that, again, I'm in California. So, and I'm very close to Mendocino County, which is the center of medical marijuana for years. Contamination is real. And when they go into these illegal sites, they're saturated with pesticides, destroyed the forests. So killed all the animals. It's horrifying. Rosa said, I appreciate you so much. Hunter's patient here. I've treated them several times. How do I rebuild my bladder so that the ulcers stop coming back? What do I do? Well, Rosa, you are in the middle of the mystery, and that is what causes ulcers. And when I started this meeting, we were talking about that. So we have research from Europe that says that it's viral, that they found a virus in the urine of patients with Hunners lesions, not in the urine of patients without Hunners lesions. So the first thing that I would want is a viral test. And you can find that research right on our website. Just go to our website, use the search command, and search for Hunners lesion virus, and you can find the papers and the citations. So my step number one would be to have a viral test, just out of curiosity, because our own National Institutes of Health confirmed it. I mean, the Europeans, this was again like 6-7 years ago, they were the first ones to find the virus, and the Americans were being very quiet about it. And I was like, guys, what do you think about the European theory that Hunners lesions are viral? And the Americans were stunningly quiet about the whole thing. Well, what I didn't know is that they were doing their own study. And they had through the MAP Research Network, which is our big IC study, they had urine that they had saved over time from like over 200 patients. And they went back and looked at that. And guess what? They found polyomavirus in like a very small percentage of patients, like 5%. So that would be the one thing I would want to know is there an active viral infection? Because then they could potentially use an antiviral and you could potentially use some lysine. But then we have this other case of this woman who had severe Hunners lesion disease, but she also had a prolapse. And when they went in to repair the prolapse, her uterus was flipped backwards. The back of her uterus was facing front and the front of her uterus was facing back because one of the ligaments that normally holds your uterus in place was broken. So her uterus was swinging back and forth, back and forth. She was in agony. So when they went in and restored the proper position, something remarkable happened. Her lesions healed completely. She is considered a complete cure. Why? So that supports a theory that for other patients with lesions, it's neuroinflammatory, that we have a nerve that has become severely inflamed, and an inflamed nerve releases substance P, which damages tissue and causes a lesion. So that would be something else that I would want to know is there any chance that you might have what we call posterior fornix syndrome? And they can do that easily with a gynecological exam. They just use a little wooden speculum and put it where the ligament should be. And if that makes the pain go away, bam, perfect diagnosis. So you can find that article on our website too. As to rebuilding your bladder, it's not a question of rebuilding your bladder. It's a question of trying to figure out what's causing the ulcer. I think what you should be doing, since you have active ulcers, is protecting your bladder. That means diet is everything for you. The last thing you want to do is pour green tea into a lesion. It's going to hurt like hell. Your job is to create an environment that will support healing and calming nerves. And so I would be following the IC diet to a T. I wouldn't be pushing it at all. And then, you know, we don't have any data that can answer that question. Bladder builder might be interesting because it can coat your bladder with a chondroitin and it's got the nerve calming agent in it. That might be it would be an interesting experiment, but there's just no guarantees. It's a guess. Allopath might be soothing, again, less because of the aloe, more because of the PEA in it. It might be interesting, but I just don't have any data. I wish I had it, honey. I just don't. Katie says, can you repeat the name of the vitamin? Yeah, it's called Bladder Smart. And these are all over in the IC Network store. Just go to icnetwork.org and click on shop, and you can find them all in the IC Network store. You know, people ask me, they say, why are you selling supplements? I'll tell you exactly why. When I started the IC Network, I paid for everything for 5 years. If you followed the IC Network, our website's completely free. This meeting is free. I'm not asking for anything from you. I'm just trying to be a support group leader. And because I am the longest serving support group leader in the United States, and I love doing this. But I came to a point where, you know, I ran out of money. I was living on credit cards. I couldn't work because of my IC, and I was just like, all right, I'm gonna have to shut it down. I have no money. And so we had a brainstorming session, and I sent out a survey to our members because by that time we didn't even have a magazine back then. I probably had 5,000 members, something like that. And what did they say? They said, don't ask us for money for everything. Don't be that way. Because back in those days, I had to pay $8 for an article from the ICA, and I was an ICA support group leader. So what they said to me was, don't charge us for information like that. I'm like, okay. And we looked at grants, and there was no money. There was no money. Listen, guys, I worked as a fund developer for a national nonprofit. I know how to do a fund development assessment. There was nothing to be had for IC. So one of my other members said, Jill, you're an educator, be a health education company. And that's what we did. So the IC Network is actually a health education company. Now, so we sold books and chair cushions and heating pads. I had no interest in selling supplements. I was a pharmacologist, for God's sake. I was Miss Conservative. Until one day, I got a phone call from a patient in Colorado who had been told that the only treatment for IC was surgery. And she had the surgery. She wasn't told about Elmeron. She wasn't told about diet. She wasn't told about anything. She was told that the only treatment for IC was InterStim, neuromodulation. And she had a catastrophic reaction to it. And it's just dawned on me that you needed a place to go where you could see all of your options, not just traditional options, because we don't have a lot of traditional options. We don't. There's only 2 FDA-approved meds for IC, and they both have side effects. And that's when I went, okay, well, then Dr. Theo came along and invented Cystoprotect, and he had the research to back it up. So this was the first or the second. No, we carried Pre-Leaf first, and then we carried maybe Aloe for a while, and then we carried Cystoprotect. I don't believe in suffering. And what was amazing is, I decided to do that. And I thought, man, I'm going to take shit. Excuse me. I'm going to take it. People are going to start yelling at me that I'm doing this for profit, yada, yada, yada. I'm doing it for health insurance, that's for sure. And then the AUA guidelines came out in 2011. And what did they say? Use the supplements. So it's like, yeah, baby, okay, I'm good. The national organization supports this, so it's okay. Okay. Vicki, you're welcome. Vicki says, thank you. That was a helpful rundown on the supplements. Julie said, thanks to Dr. Grace, who helped me with her product on curing hepatitis B and other deadly disease. She also assured me that it is a permanent cure. It's all about, so Addie is in South Africa, and she found a doctor who helped her with some herbal stuff. And I don't know anything about that. All I can tell you is the pictures on our Facebook page are shocking. I don't know anything about that company. I don't know what's in it. I don't know anything. Never heard of it before. They don't have a website, right? It's just Facebook. Oh my God, these pictures are awful. How to unblock fallopian tubes using herbs. Woo, that's a stretch. Trying to consider, ooh, honey, these claims would never be allowed in the United States. Never be allowed in the United States. These are really, this person would be sued by the government very, very quickly for the claims that she's making. Now, you got to have the proof. Where's the research to back it up? You know, we got to have the research to back it up. And that's the thing is we have the research on chondroitin. We have the research on quercetin. Herbs are another story. Jennifer, thank you so much for the 200 stars. I really appreciate that. Lisa said, would bladder rest or Peora be best to take when I have many sensitivities and urgency? Yes, and I think that those are the two most sensitive. Peora, there were no side effects in the PEA-IC study. I am uber careful about stuff that I take, and I can tell you, absolutely, I've never had a problem with Peora. I've never taken bladder rest myself because my bladder rest is healthy. I did take Cysto Protect, and the chondroitin supplements did give me some loose bowel. Jackie says, thanks for the insight on CBD. For the bladder supplements you covered, are you aware if they all contain sulfa? I tried Cysto Renew and had a horrible bladder reaction. So you have a sensitivity to chondroitin sulfate. So if that's the case, then you're really going to be looking at aloe potentially or Peora, because Peora does not contain any chondroitin sulfate in it. That actually I've worked with other patients who had issues with sulfates and sulfas. Jackie, thank you so much for the 530 stars. That is amazing. Thank you so much. Loretta says, thank you for today's meeting. Can we do a meeting with a discussion about IBS and the bladder? It's a challenge. Yeah, you know what? Absolutely. Absolutely. Rosa says, you're amazing, Jill. You know more than my doctors. Well, honey, it's just because I study it every day. Mercedes says, what do I think of the Microgen DX test? I have many UTIs, and I think I'm not being treated. I am a massive supporter of Microgen. Next generation DNA urine testing is the future of urine testing. Microgen is one of a couple companies that do it, where and I literally just talked about this in a blog on UTIs I just put up last night on our website. You know, you have 3 ways you can figure out if you have a UTI. Number 1, a dipstick. You pee in a cup, stick a little dipstick in it, and it might come back positive. If you're positive leukocytes, that doesn't really mean that much. If you're positive nitrites, you absolutely have infection, because nitrites are only produced by bacteria, by a pathogenic bacterial infection. Okay, okay, guys, let me walk you through this. It's a Friday freaking night. It is midnight. You cannot pee. You're peeing every 15 minutes. You're going, oh my God, why does this always happen on a weekend when I can't talk to my doctor? And you feels like infection. You're like 100% sure that you have infection. So here you go. Whoops. And I apologize for being so casual, but it's hot as hell here. So there's no dressing up. I didn't even wash my hair. All right. So your first step is going to be to use something like an azo urine test. You pee in a cup, you stick the dipstick in the cup, and it comes with, where's my sample? Oh, here it is. Okay. So here you go. Let me put it on its side. So you can see that there are 2 raised test pads at the end. So you're sitting on the toilet, you're peeing, you stick it in there, get it wet with urine, put it on your sink for 2 minutes. And let's see if the color of the pad changes. Right, so you can see the top pad here is a pale pink, and the darker pad is a darker pink. Now that's what happens with time. This is not something I saved, okay? That's just what happens to the chemical reagents over time. Most of the time when you're having a flare, these are going to stay white. Okay. Or you could have the top one here. The top one is leukocytes. It's quite possible to have the top one turn pink when you're having a flare, even if it's not infection, because your body is always trying to fight irritation and it sends blood vessels to the area and leukocytes to the area. But the bottom panel is for nitrites. And if this bottom panel turns color, dark purple, you have infection. Nitrites are produced. So here is the master. Do I have that upside down? I do. Okay. So you can see the top one will turn purple. That's the leukocytes. And the bottom one will turn kind of burgundy, redder. Okay. If you have positive nitrites, you have infection. No doubt about it. The problem is that this can do a false positive or a false negative. Okay, that's a whole nother story. That's a problem. You know, it's over the counter. Take a picture of it with your cell phone, email your doctor and say, hey, I got positive nitrites. I think I have an infection. And the doctor should immediately order a urine culture. Do not self-medicate with antibiotics. For God's sake, do not do that. Not yet. Because if you do that, they won't be able to identify what bug you have, what bacteria you have. So you got to just hold on tight and try to get yourself to a lab, try to get yourself to the doctor's office and pee in a cup and let them do a urine culture. Okay? Now, in the old days, your doctor would just prescribe an antibiotic over the phone. We don't do that anymore. We cannot do that anymore because that is why we have such a high level of antibiotic resistance in the world. Now we do something called antibiotic stewardship. And so the rule is we really don't want to give you antibiotics over the phone. We want to try to identify what you've got first. And so you leave your urine. It takes 24 to 48 hours. They're going to try to grow it out in a culture to see if you've got any pathogens in there. Now, the problem with a culture, for anybody who took microbiology, you know what an agar plate is. Little round plastic thing, and you put liquid in there. It's called a growth medium. It's bacteria food. And it's like Jell-O. It gets firm, and then you take your little swab of urine and you do this, and you put it over the agar plate, and you put it in the incubator for 24 hours, and you see what grows. My senior project when I got my pharmacology degree was the isolation of drug-resistant bacteria. Okay, I did this a lot. And we wait and see what grows. And then based upon what grows, that lab can then tell your doctor, hey, she's got an E. coli infection, or he's got an E. coli infection. Here are the suggested antibiotics. The second part of a urine culture that is even more important than the culture is called antibiotic sensitivity testing. Because we would like to know what is the best antibiotic to kill that infection. Because now we have such high drug resistances. I had a patient call me. This was like 2 weeks ago. She sent me her next gen test. Her bladder infection was resistant to 17 antibiotics. I've never seen one that bad. That was amazing. So we don't want to just throw a broad spectrum antibiotic out there. The odds are it's already resistant to it. We need more specific information. So now I've got this agar plate that's covered with what looks like mold, this bacteria, and I put little samples of antibiotic on it to see what kills it. Okay. The problem with the urine culture is it only identifies the bacteria which eat that food. And so it will miss like 90% of the potential bacteria that are actually in your bladder. Thus, we now come to the single most important way of testing urine, which is our future, which is next generation DNA urine testing. They take a little, like literally a quarter teaspoon or a half teaspoon of urine, and they don't try to grow anything. They just look for DNA from bacteria. And it will tell you everything living in your urine, good bacteria, bad bacteria, fungus, and maybe even virus. The advantage of next generation urine testing is that it will also identify antibiotic resistance genes. And that's massive. That's massive. It's so important to have that information so that you don't waste 6 weeks on an antibiotic that will not kill it. And now you've got a kidney infection that could kill you. You know, kidney infections can be deadly. So we want to make sure that we get the right antibiotic to kill your unique infection. Now, I have, let me see if I can find it here. Here you go. So let me show you some next gen results. So this was a next generation test that I had done because I had, after my hysterectomy, very cloudy urine. And I thought I had an infection. And I know you can't see this, but let me just see if I can. Whoops. So here are the 4 bacteria it identified in my urine: Lactobacillus, Prevotera, Streptococcus, and Gardnerella, but they didn't find anything. I mean, they say it, but like there was no percentage. So I was 92% Lactobacillus, which is a natural, a normal bacteria, but I did have Prevotella and Streptococcus. The other thing that a next generation test will give you is it will then tell us here which antibiotics are resistant or might be effective. And I know that this is backwards for some of you, and I apologize for that. And so it will rate the infection with the antibiotics. So for me, so we were trying, you know, did we want to attack the Prevotella or the Streptococcus? There was no antibiotic that killed both of them. Penicillin killed the Streptococcus, but not the Prevotella. Flagyl killed the Prevotella, but not the Streptococcus, right? Now, in the end for me, because I was not having pain or symptoms, I just had cloudy urine, we decided not to treat it at all. It's like, why do I want to destroy my biome? Why do I want to destroy my biome with antibiotics when the only thing that's going on is cloudy urine? I mean, I wasn't peeing a lot. I didn't have typical symptoms of frequency urgency. I didn't have burning in my urethra. I didn't have fever. I asked Rick, the guy who owns Microgen, I said, how do you differentiate? How do you know when to treat? And he said, well, it's a combination of 2 things. It's a combination of what do your lab results say combined with what are your symptoms. If your next gen test shows that you've got some bacteria in there, but you have absolutely no bladder symptoms, then don't treat. But if you have the combination of the 2, then yeah, then that's a suggestion of treating. And it might be a fairly rigorous treatment protocol, like for the woman who sent me her next gen test. And she was, man, I like have never seen anything like that. I've never seen a test that bad. She almost had a superbug. And she didn't want to do antibiotics, and she sent it to me. And I was like kind of groaning over the phone going, honey, this is really severe. Do not take this lightly. You have a really wicked infection. So anyway, I'm very much in support of next generation DNA urine testing. Jennifer, thank you so much for the 310 stars. It means the world. Thank you so much. And for anybody else who you find these meaningful, please come on over to the IC Network and sign up to get our free newsletter. But you can also become a member and get our magazine, the IC Optimist, which is where that's my passion, our magazine. That's where I do very in-depth articles that you don't find on our website as often. If I do put them on my website, I put them 6 months or a year later. That's really the current in-depth stuff. And so like the new AUA guidelines, new EAU guidelines, new research, all that sort of stuff. Gloria says, I have SI joint dysfunction in both sides. What did you do again? Physical therapy, hon. I'm wearing an SI belt. You probably need to be wearing an SI belt to hold them together. Jennifer says, I'm still in the diagnosis phase. What are your thoughts on trying vaginal Valium? Honey, listen, stop with the worry about addiction. I chaired the state of California pain conference years ago. I testified up in Sacramento about this when we passed our pain patients bill of rights in the state of California. An addict takes medication to escape life. You're not doing that. You're taking medication so that you can function. There's no reason for you to worry that you're going to become an addict because you're trying to figure out what's going on and you're trying to do the work you need to do. And it's actually very, very rare. I think for patients who are using pain medication from one provider, low dose, I think the rate of addiction is like 2%. I mean, it's tiny, 2 to 3%. Don't quote me on that, but I think I remember hearing a figure like that. Vaginal Valium would be a very interesting experiment because Valium is a muscle relaxant. And when you use it vaginally in the form of a suppository, you deliver that muscle relaxant directly to your pelvic floor. Okay, that's really exciting because if it turns your pain off, then you've just de facto confirmed that your pelvic floor is the source of your problem. So that should then immediately compel you to go or start working on your pelvic floor with a physical therapist. And you can save the vaginal Valium for after sex. You know, I will tell you, I've never used vaginal Valium because it's never been offered to me. But would I have used it when my pelvic floor was a mess? Absolutely, I would have given it a shot. You know, and it's about finding a dose that works for you and stuff. But, you know, muscles require muscle work. Muscles require muscle work. In the end, it's going to be about a finger inside your vagina touching muscles that's going to make this better. It might help reduce some of those symptoms, but we have got to get to the underlying problem. And the underlying problem here is tight muscles. And it takes a finger working on these muscles to try to restore normal muscle tone. Alyssa, thank you so much for the 310 stars. You guys are so generous today. Thank you, thank you, thank you. John said, how do we get urologists to start using next-gen tests and insurance to cover it? You know, I think that the problem is that insurance companies don't want to pay for next-generation consulting. You know, doctors have their formulary. Insurance companies have their, if your doctor is part of a, like Kaiser or whatever, they have their pre-written lists of things that they want to do. And that's motivated based on cost. And so I can remember when I went to my gynecologist and said, I want to have a next-gen test. She goes, no. And I said, why? And she goes, well, we don't believe in that. And I went, well, the National Institutes of Health uses it. And our cultures are not identifying anything for me. So I would like to try it. She goes, no. And I said, well, what if I pay for it? And she goes, would you just sign the form? And she's like, no. I was like, why? It's not costing you anything. It's data. It's data. I'm a scientist. You're a scientist. Don't you want data? And she's like, well, kind of. And I said, okay, I'll pay for it. Would you sign it? And she goes, yes. And she signed it. And that's how I got this done. It took some. So I think that what we have to do is present the information from the AUA to the urologist. Like we had last year at the AUA conference, a keynote speech in which Dr. Curtis Nichols said, this is our future. Cultures are a waste. You've been doing them for 80 years. we know they're flawed. We know they're not going to grow out everything because not every bacteria eats the same food. A next generation urine test is far more accurate and reliable. So I would say look for articles on the internet written by doctors, really credible doctors, and pass them along. And if it means that you've got to pay for it a couple of times, I mean, I built a website on this, bladderhealth.org. You can go over there, bladderhealth.org, and watch a bunch of videos of urologists who use it. And so that's kind of a start. Booty says, I really wanted to thanks and also introduce the real and true herbal legend, Dr. Grace, for herbal medication who cured you of herpes. Well, herpes is not part of IC. Honey, this is not a herpes support group. And so let's, yeah, we're just not going to go there, hon. I'm sorry. You can't use this to support. You can't use this to try to sell stuff. Mercedes, let me go get an SI belt so you can see it. Hold on. Okay. So if we look at this joint, so again, here's the sacrum, and the sacroiliac joint connects the sacrum to the hip bone. So if we look at it on the inside, it's easier to see it here. Now, normally this joint is very stable. It's not supposed to move. But for some of us, the joint starts to move more, and that's very painful. And so one of the ways that you can stabilize it is with an SI belt. And this is a big one. I have a big one and a small one. And so let's see. Okay, I'm losing weight, but I'm still fat. Okay. So I'm going to put it right over that. And it's got Velcro, and you attach it, right? And so now everything is held together. Okay, this is a wide one. The challenge with these belts, it can drive you crazy, is they can give you a muffin top. I use the rare times I used to wear this all the time. This was my night one. I have a smaller one for the day that's dark blue. And people never know you're wearing it. You just have to find the right match for you. But an SI belt, I mean, as soon as I put the SI belt on, a lot of my pain went away that first time when they said, hey, go try an SI belt and see if that helps. Arlene says, my doctor is trying low-dose naltrexone. Any opinion? Worth a shot. Got some good research with low-dose naltrexone. Where do you get the belt? Just at Amazon. I got the white one at my local medical supply store, and then I got my blue one on Amazon. Super easy. All right, guys, listen, it's after 4 o'clock. We are now in a flex alert, which means we have to turn off we have to really try to turn off all of our power. So I'm going to have to say good evening. Thank you for coming today. And if you find these meetings helpful, please come on over to the IC Network and learn more about IC. I'll tell you, I've got huge plans. I'm going to rebuild the front end of our website. I'm going to have a pathway for newly diagnosed patients, a pathway for grizzled veterans. I'm Just huge plans. I'm excited. Got a lot of things going on, but most importantly, please remember, September is IC Awareness Month. Go on over icawareness.org, check it out, and if you can, please send our press release out to your local papers, and let's just try to do something, anything. If not you, who? Again, like I said when I started this meeting, it's not like there's a big pharmaceutical company with $1 million running this. We're running this grassroots off the skin of our, you know what. And so I wrote the press release, and if you can help us spread it, share it, that would be absolutely fantastic. We want your posters. We want memes. If you want to do memes, there are contests about that. We'd love to hear your stories. There's an area where you can share your story. Let's just be there for each other, okay? Last but not least, I'm going to end this meeting with something that I wanted to share with you guys. So hold on, let me find it. Okay, this was probably one of the best things I've ever read on Twitter. And it was how to avoid burnout. And I think that this really applies to us, especially in the era of COVID and fires and all that sort of stuff. That you have to get 7 different types of rest. The first type of rest is sleeping, that you need physical rest, that the lack of sleep and overtraining deplete your energy. Of course, that's hard when you have IC and you're getting up every half hour or an hour. Please, again, sleep disruption is often caused by bladder irritation from food. So you got to really work on that. So try to do the best you can to improve your sleep quality. The second thing is mental rest. I really hadn't thought about it. I mean, guys, I really burned out this summer. I got to tell you, my anxiety went off the roof for a couple of weeks. Mental rest is caused by overtaxing your thinking. And my brain, I'm always like going from A to B to C to D, and what do I need to do, and what do I need to do? They're talking very specifically about, take a break from problem solving. Create a shutdown ritual to separate your work and life. Meditate. I like that. Then there's social rest. Spend time with people who give you energy. More time, spend less time with people who steal your energy. Hopefully I give you energy in these meetings. And if you're an introvert, block out time to be alone. Number 4, spiritual rest. Be part of something bigger than yourself. Volunteer, work a job that feels purpose-driven, or participate in faith-based activities aligned with your beliefs. Or, hey, hello, IC Awareness Month. Number 5, sensory rest. The modern individual is overstimulated. Oh, holy moly, is that true? So take a break from social media. Turn off your notifications. Limit your video meetings and set a relaxing ambiance at night using soothing music and candles. I love that. Number 6, emotional rest. Emotional rest deficit occurs when you feel like you can't be authentic, like you're an airline attendant who must always smile. So spend time with people that you can be authentic around and true with. And if you need to, talk with a therapist. I think I'm going to do that. I think I've got a couple things I want to talk over. Number 7, creative rest. Appreciate beauty in any form, whether it's natural or human. So take in a sunrise or a sunset, or go for a walk in a forest. Or if it's human created, visit a museum or an art festival, or engage with music, books, documentaries. And these are based on a book called Sacred Rest. And I just love that. I love that. I hadn't really thought about mental rest and social rest and emotional rest and creative rest. Especially we've been, for so many of us, we've been stuck at home. I'm stuck at home caring for elderly parents. Just to be out walking in a forest would be amazing. I try to walk every day, but you think about that peace. We all need that peace now, right? So much so. All right, my friends. Hopefully we'll get through this next week. Fire danger is very, very high. Lots of prayers needed. if the weather's better and we have power and we're not evacuated, hopefully I'll be able to drop in on Thursday or Friday on Facebook alone, and then next Sunday, hopefully for a support group meeting. But please be patient with me. I'm doing the best I can, but I'm a wee bit stressed myself. All right, you guys. Love. You're not alone. And if you need a pep talk, you know who to call. I give a very good pep talk. All right. I'll see you later. All right. Facebook's gone. All right, YouTube. See you later.